All right, we ready to go?
So, should we start? I think I'll just. Uh, I welcome all of you to the session today, and we will be starting with Dr. Mandi Bajaj, who is professor and vice chair at the Baylor College of Medicine in Houston, USA. He's also chief of endocrinology at the Baylor St. Luke's Medical Center and the medical director. So please go ahead with the lecture. We're very keen to hear about the basics of pharmacotherapy for type 2 diabetes.
Thank you. I'd like to thank the organizers for inviting me for this lecture today. So obviously, as I was talking to Dr. Talim, one of the things she said is, you have a vast topic. And my answer was, I'm going to have a patient-focused approach here rather than cover, the entire pharmacotherapy of type 2 diabetes in 20 minutes. And you had a fair amount of exposure already to a lot of type 2 diabetes over the last 2 days. So I'm going to change that approach a bit and teach you really about patient with type 2 diabetes, what the approach to a patient with type 2 diabetes with comorbidities should be. So let's start with a patient, a case, 55-year-old male with hypertension, type 2 diabetes, A1C 8.2 without complications, and a BMI of 33.5, currently on metformin, 1,000 milligrams twice a day. And the A1C has increased to 8.2 from 7 at the last visit. Fasting blood glucose on the lab is 105 and between 90 to 120 on home blood glucose monitoring. His last eye exam was 6 months ago, denied any diabetic retinopathy. Nephropathy, microalbuminuria present, and EGFR is 55. He denies any symptoms of neuropathy. LDL is 65 on atorvastatin 80 milligrams. He does have a history of congestive heart failure, and his ejection fraction is 40%. He has a family history of type 2 diabetes in both parents and coronary artery disease. Father had a MI at age 65. On exam, weighed 225 pounds. Otherwise, unremarkable physical exam. So, what would you recommend as treatment of his diabetes? He's on metformin. Add a GLP-1 receptor agonist, add a Dpp4 inhibitor, add a SGLT2 inhibitor, add pioglitazone, add a sulfonylurea. So this patient obviously has heart failure, has type 2 diabetes. And heart failure and type 2 diabetes are often found together. And as this study shows you, the risk for heart failure starts to increase right when the A1C crosses about 5.5 and successively goes up with increasing A1C. Now, this patient is already on metformin. And the traditional teaching is that patients with heart failure should not be on metformin because of the associated risk of tissue hypoxia and lactic acidosis. But have we wondered if there is any information on the use of metformin in patients with heart failure? And as this meta-analysis shows us, metformin is associated with reduced mortality in a meta-analysis of heart failure patients, and that is shown here, almost a 28% reduction. Interestingly, one of the studies is from here at Baylor, which Dr. David Aguilar did, and showed similar results. What about sulfonylureas and insulin? That was one of the options to add. Sulfonylureas and insulin are associated with weight gain and hypoglycemia, but are commonly used in heart failure patients. There are no large randomized control trials in patients with established heart failure, and observational studies demonstrate potential increased risk of heart failure outcomes. Again, it's an issue of marker versus mediator. And randomized trials that have included these therapies have not shown greater rates of heart failure, whether it is the UKPDS or the ADVANCE or ORIGIN or Barry 2D studies. Intensive versus standard glucose control, again, in the ACCORD, ADVANCE, UKPDS, VADT, did not reduce heart failure admission or heart failure death with the use of insulin in these patients. Again, showing you that basically insulin therapy and intensive lowering of glucose is neutral in terms of outcomes for patients with heart failure. What about the use of Dpp4 inhibitors, which I did put forward as a choice? Well, Savatimi examined TCOS and Carmelina with saxagliptin, alogliptin, sitagliptin, and linagliptin, showed us that in Savatimi, saxagliptin was associated with the increased risk of hospitalization for heart failure. With alogliptin, again, there was a trend towards an increase. With sitagliptin, you did not see that increase, and neither did you see it with linagliptin. However, they had no benefit in heart failure, both sitagliptin and linagliptin, in terms of reducing hospitalization. So again, they're not an option. What about GLP-1 receptor agonists and heart failure? Randomized control trials that you can see here, Alexa, Leader, Sustain 6, Excel, Harmony, Rewind, Pioneer 6, all showed basically that they were neutral in terms of the risk of heart failure, with no benefit with the GLP-1 receptor agonist. And here's another study that you see right here in patients with established heart failure and reduced LVEF, 300 patients with reduced LVEF, liraglutide versus placebo, and mortality did not change. Death or rehospitalization for heart failure, a small increase with liraglutide that was not statistically significant. So the bottom line is GLP-1 receptor agonists have no favorable outcomes as far as heart failure is concerned. And finally, the choice to treat them with the SGLT2 inhibitors, which is again a no-brainer because you've already looked at trials with, and these have been presented over the past 2 days. EMPA-REG, Canvas, declared TIMI, looking at empagliflozin, canagliflozin, and as well as dapagliflozin, and looking at heart failure. And it's clear that hospitalization for heart failure came down with EMPA in EMPA-REG, CANA in Canvas, and declared TIMI, cardiovascular death and heart failure hospitalization did come down. And when you look here comparing EMPA-REG with Canvas, you see one thing for sure, although the two drugs in terms of their effect on stroke and cardiovascular death was somewhat different, as far as hospitalization for heart failure, both SGLT2 inhibitors were similarly beneficial. In addition, they reduced the progression to macroalbuminuria and altered the renal composite index. And we must remember that our patient does have microalbuminuria as well as a eGFR less than 60. And finally, with ertugliflozin, again, you saw clearly cardiovascular death and heart failure here, and hospitalization for heart failure came down. The renal composite index was of borderline significance. And this is a meta-analysis of all the SGLT2 inhibitor cardiovascular outcome studies, where if the patient had atherosclerotic cardiovascular disease or no atherosclerotic cardiovascular disease, time to first hospitalization for heart failure clearly came down when all these studies with SGLT2 inhibitors. And then came the DAPA heart failure and the Emperor reduced studies, which showed that in patients with reduced ejection fractions, irrespective of whether they had diabetes or did not have diabetes, you reduced the hospitalization for heart failure significantly and cardiovascular death or hospitalization for heart failure again significant. And finally, the new studies that just came out in the last few months, EMPA in heart failure with preserved ejection fraction, and then DAPA in heart failure with preserved ejection fraction. This one showing that you reduce hospitalization for heart failure and cardiovascular death. The preserved heart failure showed that DAPA improved symptoms and physical limitations in heart failure patients with preserved ejection fraction. And then you have the last study, the DELIVER trial, baseline characteristics have already been published. The results have already been released in a press release, but it still remains to be published, and the results presented in details, basically looking at DAPA with heart failure and mildly reduced and preserved ejection fraction, and the preliminary results showing, again, reduction in cardiovascular mortality, as well as the reduction in hospitalization for heart failure. So all these results are well known. But think again, why do these drugs reduce the risk of heart failure? What is the mechanism? So you see your patient has heart failure, you have clinical trials to support your treatment. But the question is, why does a SGLT2 inhibitor reduce hospitalization for heart failure? Do we have an answer there? Can a shift in fuel energetics explain the benefit of the EMPA-REG outcome study? So when EMPA-REG came out, people were surprised to see that cardiovascular death and hospitalization for heart failure significantly decreased. And they postulated that the cardiorenal benefits of EMPA are due to a shift in myocardial and renal fuel metabolism away from fat and glucose oxidation, which are energy inefficient in the setting of a type 2 diabetic heart and kidney, towards energy efficient superfuel like ketone bodies, which improve myocardial and renal work. Again, a hypothesis. And we know very clearly that these drugs increase ketosis and ketone body formation. So the normal fuel for mitochondrial oxidative metabolism is a balance of free fatty acids, glucose, and lactate in the heart, and to a lesser degree, ketones. But in a type 2 diabetic heart, there's increased fat oxidation, decreased glucose oxidation, a decrease in P/O ratio, which leads to a decreased generation of ATP and decreased cardiac work efficacy. When you treat with SGLT2 inhibitors, they postulated, again, this is a hypothesis, that fat oxidation comes down, glucose oxidation increases, but most importantly, you have ketone bodies available, and the heart is now dependent on beta-hydroxybutyrate oxidation to a greater extent, which then results in an increase in ATP generation and increased cardiac work efficacy. Again, an unproven hypothesis in terms of heart failure and the use of SGLT2 inhibitors. So when we got the EMPA-REG studies results, we went back to the lab. This is a classic case of observing in clinical trials new information that cannot be easily explained, and going back to the lab and looking at animal models to try to explain the results. Generally, it's the other way around. And we took type 2 diabetic mice, BTPROB, and wild type mice, and treated them with DAPA or DAPA plus saxagliptin for 8 weeks, and showed that DAPA attenuated the activation of inflammation while inhibiting the inflammasome, reduced myocardial fibrosis, and this is all in a model of diabetic cardiomyopathy, and deterioration of left ventricular ejection fraction. Adding saxagliptin to DAPA did not result in any greater effect than DAPA alone on myocardial fibrosis and collagen levels. So you reduce myocardial fibrosis and reduce myocardial inflammation. And these anti-inflammatory, anti-fibrotic effects are likely independent of SGLT2, SGLT1, and glucose lowering. They are completely independent and because they were replicated in an in vitro model. We found that DAPA increases AMPK phosphorylation. AMPK is a key regulator of energy, fat oxidation, whether that be the myocardium or the liver. And DAPA augmented AMPK phosphorylation in cardiofibroblasts so that basically you increase myocardial fat oxidation, probably reduce myocardial triglyceride, and thereby produced improvements in myocardial function. We found that the effect of DAPA on LPS-induced inflammasome activation was completely blocked by an inhibitor of AMPK, compound C. So we concluded that the anti-inflammatory effects of DAPA on the myocardium are AMPK dependent. Now, this is different from the ketone hypothesis, which really suggests that you increase ketone body formation and the heart depends more in a type 2 diabetic on ketone body oxidation and increases ATP generation and work efficacy. So the American Diabetes Association 2022 clearly says first-line therapy depends on comorbidities, patient-centered treatment factors, cost, access, considerations, management needs, and generally includes metformin and comprehensive lifestyle modification, but recommends, independent of baseline A1C, individualized A1C targets, or metformin use, the use of SGLT2 inhibitors with proven results in heart failure, as well as in CKD, where these drugs reduce the progression of renal disease. Obviously, in this patient, our answer here would be add a SGLT2 inhibitor. A GLP-1 receptor agonist, as we saw with the studies, has no benefit on reducing hospitalization for heart failure. A Dpp4 inhibitor, Saxa, probably an increase in heart failure, and certainly no benefit with the others. If you add pioglitazone, you increase sodium and water retention and can worsen heart failure. And with sulfonylureas, not much of data, but clearly no benefit. So the correct answer here is to add a SGLT2 inhibitor in this patient with diabetes, possibly a cardiomyopathy, heart failure, and with early chronic kidney disease. Now, this takes us to a new approach to managing type 2 diabetes. It's important that you look at the patient, look at comorbidities, which is what the ADA has emphasized. Then choose an agent, but also consider all options and consider if this patient has this underlying comorbidity, what is the data with metformin, with GLP-1 receptor agonists, Dpp4 inhibitors, pioglitazone, SGLT2 inhibitors, and sulfonylureas as well as insulin before you take any decision. If we had another patient with non-alcoholic steatohepatitis, I would be adding a GLP-1 receptor agonist and or pioglitazone. And again, we have plenty of evidence to show benefit based on clinical trials and basic science data. So you take your clinical judgment, then go to the pathophysiology, then go to the basic science, as we did in this case, and then reach a conclusion of what is best in terms of treatment for type 2 diabetes, rather than basing it solely on the basis of a random decision in terms of choosing a agent. And that is what my father taught me, Professor J.S. Bajaj. Being his student, he always emphasized, look at science with an open mind. And as he would say, that the mind is like an umbrella. It only functions when it is open. I was fortunate to be his student. I was fortunate to be his resident. And I was fortunate that he guided me throughout my career, like many others that are with us today. And I'd like to thank the organizers for naming the hall in my father's name. But for those of us who were taught by him, this was a clear message. Go from the pathophysiology and the basic science to clinical decision-making before you make any clinical decision, whether that be in diabetes or medicine. Thank you so much.
Thank you, Dr. Bajaj. That was an excellent lecture. It was wonderful how you pointed out that we should first look at the clinical picture, then think about the pathophysiology, consider the biochemistry as well, and then finally make a decision based on the basics. And I think it was a very interesting way in you presented the case and how we finally came to the discussion and the important role of SGLT2 inhibitors in the management of diabetes today. In the US as well as in India, we consider a more patient-centric approach today rather than what was done earlier. And considering the comorbidities, considering the pathophysiology, we can finally make the right decision for our patients. Thank you very much, sir.
Thank you. Thank you for being there.
Yes. We have the next lecture, which is I welcome Dr. Graham Ogle. He would be talking about incidence and prevalence of type 1 and type 2 diabetes, and also include the results of the type 1 index. Dr. Ogle is from Australia. He is well known for his program Life for a Child program. He is professor, Faculty of Medicine and Health of the University of Sydney. I welcome you, sir. Good morning.
Welcome, Dr. Graham. I am Dr. Divya Saxena, co-chairperson of Dr. Manisha. Welcome to India and to this Diabetes India. So over to you for your lecture, sir.
Can you hear me now?
Yes, sir.
Okay. Yeah, I thank the organisers for the opportunity to speak to this meeting, and thank Dr. Bajaj for his very interesting lecture, which was at sort of the other end of the spectrum, if you like. And so I wanted to talk about three things. I wanted to talk about what we know about type 1 incidence in children and adolescents, firstly, then what the T1d index is, secondly, and then what we know about type 2 diabetes incidence in children and adolescents at the end. And these, most of what I will say is based on the IDF Atlas, which was released last December, and the accompanying papers. Sorry, there's a bit of a delay here. Okay, so what we know, the estimates are that if you look where I've highlighted in red there, there's around 1.2 million children and adolescents under the age of 20 with type 1 diabetes, with around 150,000 new cases each year. They're the best estimates that we have at the moment. And this is the incidence map of the world. So you can, now incidence is the rate of new cases. And the countries with the highest rates are those in black. And so particularly in Scandinavia and Canada, but you can also see some surprises there as well, with Algeria and Saudi Arabia also having very high rates. So it isn't just in European origin populations. And then the second band of incidence is countries like America and Australia and much of the rest of Europe. And you can see that India has a relatively low incidence, but not as low as a number of other countries. And this is what we did is we put in this paper, we put together all the information that was published. This is over various publications from various years, so it might have changed in the interim. And as I mentioned, you can see the Scandinavian countries at the top, with Kuwait and Qatar and Saudi Arabia and Algeria coming in there as well. And that's the first page of this. And then this is the second page. And you can see that India is there. It's a substantially lower incidence than some of those other countries that I was talking about. But there's a number of other countries with a lower incidence than India, including countries like China and Japan. And so that was incidence, but when it comes to prevalence, and that is the number of people living with the condition, because there's lots of Indians in the world, and particularly there's lots of Indians in India, India has for the first time in this atlas exceeded the United States in terms of the numbers of young people with diabetes. And so the estimate is that there's 229,000 young people with diabetes within India, with other high population countries like the USA, Brazil, and China coming after that. Now, why does type 1 diabetes incidence vary so much, 30 or 40-fold? Well, we all know it's an autoimmune condition. There's a complex interplay of genetic and environmental factors which affect the immune system to bring on type 1 diabetes. And we know some things, but we wish we understood more. We understand the genetics fairly well. We understand that family aggregation is only responsible for 10 to 20% of the risk. And there is actually less family inheritance happening in type 1 than in type 2. But the HLA genotype, particularly DR3 and DR4, that haplotype confers 30 to 50% of the risk, and a number of other genes are involved. And if you have an identical twin who has type 1, you have a 40% lifelong risk of developing it. If you have a sibling, you have a 4% risk by 20 years and an almost 10% risk by age 60. And then there are environmental factors. And we know that there's environmental factors because in countries where there hasn't been much migration, and so the genes probably haven't changed, the incidence of type 1 diabetes has risen and risen over the last few decades. And so something must be happening in the environment. And there's a complex interplay happening with immunity. I think the most likely thought is that it's viruses affecting the young person in infancy or early childhood, and their relative timing, and possibly changes that which is triggering changes to the immune system. There's also lots of investigation of the gut microbiome. Infant feeding does play a role, and it's better to breastfeed. The method of delivery plays a small role as well. Rapid weight gain in infancy, there may be a role for vitamin D, but we still don't really understand this very well. And we do know that rates rise in migrant families moving to high incidence countries. For example, when Indian families move to India, their children will have a higher rate of type 1 than they would if they stayed in India, and their rates approach the rates in England. And so it's complicated. And as I mentioned, incidence has been increasing, probably 3% a year or more in most countries that have data over some decades. But it does appear to be tailing off, or that increase has ceased in some high-income countries. That's debatable, but I think it's tailing off in some countries, and it's also tailed off in Japan. But in other countries, it's increasing still, sometimes at 5% or more a year. And this is some data from various countries showing this increase over the years. And some data from our work, the top bar here, the top graph is incidence. And there was, in Uzbekistan, there's a 5.6% annualized incidence over this period. And in the Maldives, which is very close to India, as you know, there's been a 12% increase over annualized increase over a decade. So what do we know about incidence in India? Well, Dr. Ramachandran in Madras measured incidence of 10.5, but then subsequent measurements have been lower than that. Incidence is a tricky thing to measure in big cities in India, in big cities anywhere. Dr. Kumar in Karnataka and his group estimated incidence at 3.8, then Dr. Kaura at 3.0 from a prevalence study. And then a study was done by the YDR team and also by the search team from America in New Delhi and Chennai in 2006 to 2012. And they found an incidence of 4.3 per 100,000. Sorry. With estimated ascertainment of 78%. So that would give you 5.5. Now, the IDF Atlas that I've just been speaking about uses this 4.3 figure, but I suspect that the incidence is actually higher than that, and maybe even that they underestimated the ascertainment. It is interesting that in Bangladesh, we've measured 1.0 and the same in Pakistan, although the Pakistan study did have incomplete ascertainment. It was double the previous estimate. But I think the incidence in Pakistan, at least, is moving up towards the Indian incidence, but we don't have any proof of that. This is the study that was done in India. This study also did look at the incidence of type 2, and I'll come back to that. But what we don't know in India, as I said, we don't know the actual incidence, because that study in Chennai, in New Delhi, may have underestimated cases by more than estimated. We don't know whether it varies across the states. You have a very diverse population there. Does it vary in urban versus rural areas? We don't know the numbers dying from non-diagnosis. And by that, I mean children who develop clinical symptoms of type 1 diabetes will have the classic polyuria and polydipsia. They'll be drinking too much and weeing too much. But then if that's not picked up, they will go into ketoacidosis. And that is so often misdiagnosed as something else, as gastroenteritis or pneumonia or typhoid or malaria or malnutrition or ectopic pregnancy or appendicitis. That there's a legion of misdiagnoses. And they're just the ones we know about. And we suspect that many die undiagnosed. And then we don't know in India whether it's increasing. If it was increasing, those studies were done a decade ago now. And if they're increasing over 3%, just at 3% a year, it would have gone up by a third already. To do an incidence study, and I won't dwell on this, there's certain things you need to do. And if you are interested in doing one and you'd like some expert advice on that, we're happy to provide that. We're actually looking to do an incidence study with Dr. Yajnik in Pune and possibly in another site in India as well. But the more, the merrier. And when you do these sorts of studies, you have to remember that type 1 occurs in adults, even older adults, and type 2 occurs in older children. And sometimes it's hard to tell, particularly in India, in the subcontinent, whether they're type 1 or type 2. There's also monogenic single gene cases. And then there's this issue of non-diagnosis. And this is, we have a competition every couple of years for the young people supported by Life for a Child. And this was a story written by a 17-year-old in Ghana. And he talks about how he got sicker and sicker over 5 months, being treated by doctors with all sorts of different things because no one picked up his diabetes. He was wetting his bed and losing weight. And then he went into ketoacidosis and started vomiting and weak. And he would have been dead within a couple of days. But fortunately, finally, the doctors made the diagnosis and now he's fine. And in the country of Mali, which is in West Africa, we published recently showing that the incidence really jumped up. It was rising quickly, but then it really jumped up between 2013 and 2014. Now, this isn't sort of a usual rate of increase of incidence. Something is happening here. And what we think happened is that this poster campaign went out to clinics just showing the signs of type 1 diabetes. And we suspect that this problem of non-diagnosis, which results in death, is still occurring in parts of India, particularly in rural areas. I've spoken with many Indian colleagues and they agree. This late diagnosis can happen all around the world, and it's a great concern. So that brings me to the T1d Index, which is a new initiative. It's a partnership between JDRF, Juvenile Diabetes Research Foundation, Life for a Child, IDF, and ISPAD, the International Society for Pediatric and Adolescent Diabetes. And what it aims to do is it aims to have good numbers, both on incidence and prevalence, for type 1 diabetes for all countries, for all ages, which is quite an ambitious outcome. And it simulates what the numbers would be and what the outcomes would be, both as it is at the moment with the best available data and how it could be if care was improved. And this has been built by a coalition of experts, and it's currently under review. I can't show you the results yet. In 2 months, I think I'll be able to, but it's currently under review, and it looks promising that this will be published. We've tested this against published data, and it's accurate to within 7% on those studies. And it shows that type 1 diabetes is growing fast, is stealing an average of 30 years of life from these young people or older people, and it doesn't have to be that way. And the purpose of the index is not just to have better numbers, but then to use those numbers to raise awareness and to raise and to improve programs, and particularly government programs, and then track and monitor progress. And so it will be the most accurate estimate of the incidence and prevalence of type 1, and it will simulate each country. And then you'll be able to explore what happens if we improve the A1C in India from, say, 9% to 7.5%, which is the target. What would that mean in terms of mortality? What would that mean in terms of reduced renal disease and that sort of thing? And the index will be, the beauty of it, I think, is it'll be available completely open source, and there'll be dashboards on the internet that you can change your levers and dial up the country that you like. And so how do we get the numbers? We feed in all the incidence data that we have into what's essentially a Markov model. And so each new case joins the group of people living with type 1 diabetes. And then we apply mortality rates on those. Were they diagnosed? And secondly, what's their mortality when might they die? And this is all put into a complex mathematical model to give the numbers. But also we can using data from the University of Pittsburgh, we can look at the complications, estimate complications and the burden of disease as well. And we can also estimate how many there should be if care had have been the best possible care. And you can see that in India, for instance, or in South Asia, there's a lot of people who've already died from type 1 diabetes. They're all around the world. but particularly in less resource countries. And of course, it depends where you are in India and what access you have. But there's a lot of people who aren't with us now because they've died, and the index can estimate that. And this is an example of the dashboard. Forgive my scribblings, but I just had to scribble out the numbers because we can't release them yet. But essentially, you can dial up any country that you want and any year that you want, and the numbers will be there for you to see. And as more information comes on, this will be refined and improved. It'll be a sort of a living document. And so for India, this will show the numbers over the period and the life expectancy and that sort of thing. And then there'll be lots of other information there as well for those who are interested in it. So in 2 months, we should be able to show you that. And then finally, I wanted to talk about type 2. And we know a lot less about type 2 incidence and prevalence than we do about type 1. And I think there's a couple of reasons for that. Firstly, type 1 has been around for a long time. People have only more recently thought about type 2 in children, but we all know that it happens and it's increasing. And secondly, you remember that I explained how a child with type 1 will either be diagnosed or they die. Well, that doesn't happen with type 2. Type 2, children with type 2 can live on. They're just unwell, and they're cooking their kidneys and their eyes. And I think one important message I'd like to say, it isn't the topic of this talk, is that there's very strong data from India, from Australia, from America, that young people with type 2 develop complications quicker than young people with type 1, and they need to be treated aggressively. So this is another Atlas paper that was just published. And this is the best data we have from India from that same study, a lower rate than type 1, but how many cases are being missed? Because it's probably a lot higher than this. Interestingly, the incidence from India is similar to Bangladesh and also similar to Fiji, which has a large Indian population as well. And so this was the estimates of numbers, with the Western Pacific having the most because of China and Japan, which have higher rates of type 2. But I suspect as we get better data from India, the numbers of young people with type 2 as well in India will be much higher. And as I mentioned, this is a great concern. And so on the incident cases, just given India's population, there's around 4,000 young people with type 2 diabetes, developing type 2 diabetes every year in India. But I think that's a substantial underestimate. And then finally, Life for a Child, the program that we manage here from Sydney. We're helping in over 40 countries, including a number of centres in India. And our vision is that no child should die of diabetes. And what we do is we work with existing centres. You won't go anywhere and find a Life for a Child centre. You'll find CMC, or you'll find Diacare, or you'll find Dream Trust, and we support them as best we can according to their needs and our resources. And we do a lot of research. And if we can help your centre, if you're interested in approaching us for support, please contact me. There's my email there, or just Google Life for a Child. So thank you very much.
Thank you so much, sir, for such a wonderful deliberation of a very important subject, that is what is the incidence of type 1 diabetes in comparison to type 2 diabetes all over the world. And when we can know the numbers, we can exactly catch hold of the patient at right time, and we can very well manage these patients at the right time and prevent the complications and so many deaths. So thank you once again, sir, for the wonderful lecture. And the questions will be addressed at the end of this session. Thank you once again. So moving towards the next session, it's another very interesting subject, that is diabetic foot. And we all know that the second most common cause of foot amputation all over the world is diabetic foot. And if we can prevent it, and if we can detect it at the right time, we can salvage many foot. So for this very interesting session, we have a very eminent speaker, Dr. J.G. Abbas among us. So he is a consultant physician, endocrinologist, and diabetologist. He has been awarded with FRCP honors from Royal College of Physicians and Surgeons, Glasgow, and London as well. He is currently president-elect of Diabetic Food International. He is chair of Pan-African Diabetic Food Study Group. He is an executive board member of IWGDF for the International Consensus of Diabetic Food, and he is vice president of Association of International Medical College of the Extremity. And he's also a member of so many organizations. He has published extensively on the epidemiology of diabetic limb complications, and he has written several book chapters also on diabetic food. So, sir, over to you for your deliberation. Over to you, sir.
Thank you very much. Good morning, good afternoon, or good evening, wherever you are in the world. I'm going to give a talk today on multidiscipline management of diabetic foot ulcers. Can we do better? Before I start my talk, I would like to thank organizing committee for inviting me to give this talk, and especially Dr. Bansi. I come from Dar es Salaam, Tanzania, which is at the east coast of Africa. It's the land of Kilimanjaro, Mount Kilimanjaro, Ngorongoro Crater, Serengeti Park, which is the largest park in the world, and Zanzibar Stone Town. If we look at in the world, Africa and Asia, two largest continents in the world, the population, about 76% of the population caters by these two continents, and 80% of the patients, diabetic patients, come from this underdeveloped region. Rest of the world is 24%, that is North America, South America, and Antarctica, Europe, and Australia. So we are going to have a double burden. We have not yet finished with communicable disease, and we are catering for non-communicable disease. That is 80% of diabetics from this region. Look at the prevalence in Africa. Where were we 20 years ago? 7.1 million. And in 2021, that is after 20 years, 24 million. And it has been predicted now we are going to lead the world in 2045, that is next 20 years, by 55 million, which is an increase of 129%. Let's look at the diabetic foot complication. What is the real situation on the ground? Food complications. Worldwide, there is an increase in diabetes. So simultaneously, parallel, there will be increase in diabetes complications. Of these complications, foods are going to be predominant and dreadful complications. It's a major public health problem, main cause of prolonged hospital admissions. Cost will not be sustainable by the patient's family, relatives, friends, community, society, or nation at large. Commonly in our setup, the underdeveloping country, is an infectious etiology in our setup that and it is associated with underlying peripheral neuropathy and peripheral arterial disease. Gangrene and infection are the most common underlying reason for foot amputation. True prevalence in developing world will never be known, which always will remain underestimated because we do not know what is happening at the rural areas. Published reports implicate that delayed presentation is an important risk factor for amputations and mortality in our setup. And most of the patients who need amputations die before the surgery due to infection. Time is tissue in diabetic foot, and these are the feet where time is not tissue. These feet have a history of weeks and months of ulcers, inability to walk, infections, misdiagnosis, and treatment. Typical sequential timeline of patient's decision to seek medical help in underdeveloped country is as follows. First, the patient would initiate treatment at home by herbal bath, use of razor blades to cut the callosity, that is a bathroom surgery. Then they will visit to a herbal or a fat healer or a traditional healer. Once they fail there, then they go to the primary health center where there is no facility or expertise of the diabetic food care, and then lastly they will visit to a district or a regional health center. But thus, by the time the patient is finally referred to a specialized referred hospital or a specialized food center, it is often too late to save the food or even prevent the death of the patient. 2005 was a diabetic foot year, and it was estimated that an amputation every 30 seconds is due to diabetes somewhere in the world. So 2 amputations in a minute. And same thing was quoted in a Lancet and that year, that every 30 seconds a lower limb is lost somewhere in the world due to diabetes. In 2017, we again estimated and found that it was actually gone from 30 seconds to 20 seconds an amputation. This means that it was 2 amputation in every 1 minute. Now it has gone to 3 amputation in a minute. With so many conferences, seminars, workshops, hands-on workshops, and still no improvement. So we have actually gone from bad to worse. This is one of the slides from Muhimbili National Hospital, which is a university hospital, and if you see at the highlighted words, you can see that the thing which I have highlighted, 33% of the patients underwent amputation, 54% of the patients died due to severe foot ulcers, so the late presentation Wagner 4 or more, and overall mortality in this was 27%. This is same all over the Africa. If you do a literature review survey in past 20 years, you will see high rates of amputations every corner of the Africa and mortality. If you look at the prevalence of diabetic peripheral neuropathy in Africa, more or less is the similar what we see in the Western world in double digit. This was one of the study which we did it, myself, Dr. Steven Mobeck from Germany and Dr. Vijay Vishwanath from India, and we found that wherever you are in any continent of the world, peripheral neuropathy is similar. And you can see there is no difference whether you are in Germany, Tanzania or India. Peripheral arterial disease, if you look at it, the last 15 to 20 years in Africa, it is going up and it is all going to the double digit and similar at the par what we see in the Western world. But if you look at it just before 1990s, we were in a single digit and it was like non-existing in Africa. So we have developed at the cost of health by adopting the Western lifestyle. Economic burden of diabetic food. You cannot speak about diabetic food without economic burden. This was a study which we did it in 5 countries in 4 continents. Dr. Chris Estinger from United States, Dr. Nina Rogers from Chile, Dr. Zhu from China, myself from Tanzania, Africa, and Dr. Arun Bal from India. And so there are 5 countries, 4 continents. And what I'm going to talk is on in Tanzania. If you look at it, the cost of Tanzania is lower than rest of the 5 countries, but it is still high. It's a $3,000 to treat this hypothetical photo which has been which has been shown on the left side of this slide. So it is almost 25 months of that bread earner. And as we know, in developing world, whether we are in Africa or Asia, the bread earner would be more, and then you have an extended family. So it's a huge burden to the family, community, society, and the nation at whole. Socio-economic factors. We have still not finished with socio-economic factors. People are still not aware of the rural areas of barefoot walking, inappropriate footwear, tendency of patients to see fat healers, and so on. Non-ulcerative pathology of ulcers. These are due to these are the reasons. These are non-ulcerative ulcers. Pathology of ulcers are due to the patients when they come to the clinic and we ignore or we not check the food properly. Patient could have been a careless fungal infections, dry skins or cracks, gross deformity of nails, tradition. All this, if it has been checked properly on regular basis, we should have saved a lot of morbidity and even mortality. So can we do better with multidiscipline team management of diabetic foot ulcers in our part of the world. Many discrepancies from the best clinical practice have been shown and can be identified that non-existing diabetic foot ulcers teams are in our establishment in best clinic, absent coordination of the foot care, solo worker of the health professional leading to inefficiency communications with other health workers, lack of knowledge about the roles and scope of the practice of this discipline, lack of training among the staffs, inability to prioritize co-current needs which are needed in patients with chronic disease and etc. Growing body of evidence supports that the presence of integrated foot care based on multidiscipline and interdiscipline teams in the management and prevention of diabetic foods is worldwide. Indeed, it has been reported and shown that integrated food care based on multidiscipline teams reduces the complications such as total amputation numbers by 49% to even 85% in some centers in the patients with a high-risk diabetic foot. Unfortunately, this supported model of care remains largely not achievable in our part of the world. Multidiscipline management of diabetic foot complications, it is also now requirement in other parts of the world that a multidiscipline food clinic with the following objectives. To reduce the number of minor and major amputations arising from diabetic foot attack, which I have already mentioned, to reduce the unnecessary admission to hospital in the event of diabetic foot attack, to provide a seamless care pathway with the foot protection services in community to avoid diabetic foot attack. It has been highlighted that the central role is that a proper care and a management of diabetic foot service which is leading to a diabetic foot attack. So if we have a case of diabetic foot attack, it has to be a system. There has to be a system and algorithm from the primary healthcare center to the tertiary center, and it has to be taken care properly same time. Diabetic foot attack is an attack is same like an heart attack or a cerebrovascular stroke. Multidiscipline or interdiscipline team, that is a patient center, and this composed, so that means you can have a multidiscipline team, but the interdiscipline team is now more proper than multi. So they interact each other. There will be a diabetologist, angiologist, vascular surgeon, orthopedic surgeon, microbiologist, X-ray radiologist, or a general surgeon, or a physician, educator, podiatrist, and nurses. All they come along under one roof and discuss regarding the patient. This is the same thing which I have shown you in the previous slide, that all this multidiscipline specialty has to come under one, and where the center is a patient. The results have shown, well, let's see a multidiscipline team impact on the hospital admission and amputation. The results have shown that the full established one-stop multidiscipline team led to diabetic foot clinic. A fully established one-stop diabetic foot clinic will benefit patients and improve the outcome related to avoidance of hospital admission, limb salvage procedures, minor amputations, although we recognize that the time and educations are needed to see its full effects applied. Go beyond a multidiscipline team approach for the management of diabetic foot. Multidiscipline team are associated with reduction in amputations. Multidiscipline team care is effective strategy for the highest risk patients, and especially those with ulcers severe enough to warrant hospitalization and underlying peripheral arterial disease. In our setup, infection is also important. It is consistent with an expert opinion guidelines suggesting a tiered approach to care based on ulcer severity. Multidisciplinary teams are associated with reduction in amputation. It is in this model, primary care is responsible for preventing the foot ulcers, so it has to be started at the primary center. Relatively straightforward ulcers can be managed at the grassroots level, locally at the primary or a district, or even at the regional level before it reaches to the tertiary level. Large multidisciplinary teams like tertiary care can take care and reserve for the patients with a severe and a complicated foot ulcers. This model depends on effective triage so that the patients receive the appropriate level of the care at all from primary, district, regional or tertiary level. And this is, if you do this, you can save a lot of fits and mortality. Clinicians starting a multidisciplinary team may want to incorporate these elements, and research may opt to investigate in which common elements are necessary, core elements for success. With this in mind, we noted the following things. So these are the common elements for the successful multidisciplinary team. Number one, a team should compose of medical and surgical discipline, not medical alone or surgical. A larger team would benefit to have one captain to run to sail the ship, and a nuclear or an ancillary team member structure. Clear referral pathway, a care algorithm supporting timely, comprehensive care. Each of the preceding elements address work system condition that enables the multidisciplinary team to perform their task consistently, collaboratively, and rapidly. A multidiscipline address 4 key tasks: glycemic control, local wound management including surgical debridement and minor amputation, diagnosis and management of the vascular disease including revascularization if possible, and diagnosis and management of the infection more commonly in our setup. Let's see what are the implementation of multidisciplinary team around the world. Implementation of multidisciplinary team have been found to be successful in many areas around the world. The information which I'm going to give you a few examples and the impact of multidisciplinary team to save amputation. A study took place in Sweden, the Lund University, to understand the long-term incidence of amputation in diabetic patients following the implementation of this multidisciplinary team in Lund. The population study indicated 75% decrease in major amputation, an increase in minor amputation from 28% to 53%, and re-amputation rate decreased from 32 to 22%. There were many factors that have influenced the possibility of avoiding amputation. The study included the following factors: increased availability of preventive foot care, protective shoe wear, and increased focus on the patient, an early coordinated evaluation of possible limiting factors for healing, and implementation with a minimum of delay, that is a very important point, of optimum strategies to achieve maximum healing. There were many factors that influenced increased use of non-invasive vascular testing, maintenance of strict amputation criteria and criteria for primary level selection. A long-term follow-up after healing is also important, either primary or after amputation. This is important to note that 50% of diabetic patients with foot ulcers develop a new lesion within 2 years of observation. Another study done at the Army Medical Center in USA after the implementation of multidisciplinary foot care, a study found an increase in in patients diagnosed with diabetes 48%, 82% decreased in lower limb amputations, and use of multidisciplinary team showed decreased rates of amputation. The multidisciplinary diabetic foot care approaches has been shown to decrease the rate of amputations, which positively affected the health and quality of life of the patients, and also associated with relatively low cost. The multidisciplinary approach can help to address a multifactorial process associated with diabetic foot. This approach has been shown to delay the rates of amputation through early identification and obviously early intervention. Another study was done in Turkey, one of the Turkey universities, that gathered data on diabetic foot ulcers. Patients were treated by primary physician, and then a multidisciplinary diabetic team was implemented at those centers. The implementation of multidisciplinary diabetic foot care team resulted in decrease in major amputation from 20% to 12%, and this is a tremendous achievement through multidisciplinary team. So, ladies and gentlemen, in conclusion, there is an urgent need to reassess the care pathway pertaining to diabetic foot ulcer management in our health system, especially in developing world, as we sense the overall gravity of this diagnosis is underestimated. The concomitant level of lack of prevention, inefficiency, early detection, and often inadequate management of ulcers often lead to eventually high morbidity and mortality. The multidisciplinary diabetic foot clinic has proved a unique forum to provide urgent treatment of infection, ischemia, with rapid access to laboratory, radiological, and inpatient facility. Multidisciplinary teams, especially those able to address glycemic control, local wound management, vascular disease, and infections, are associated with reduced risk of major amputations for the patient with severe diabetic foot ulceration. One-stop multidisciplinary team led to a diabetic foot clinic benefits patients, improve outcome related to avoidance of hospital admission, very important here, limb salvage procedures, minor amputations, although we recognize that the time and educations are needed to see its very full effects. If I have given you too much information and you've lost the way, then ladies and gentlemen, can you just take this last take-home message, how to prevent foot problem? Regular inspection and examination of the feet, identification of high-risk foot, education of the patient's family and healthcare workers, which we are doing at the moment, appropriate footwear, and treatment of non-ulcerative pathology intervention has to be taken if the patient comes in the clinic. So take these 5 points and we can save a lot of amputations and mortality. The last slide, which I'm going to say from the saying of Mahatma Gandhi, the great leader of India, live as if you were to die tomorrow, but learn, that means educate, as if you were to live forever. And another great guy was Nelson Mandela from Africa. Education is the most powerful weapon which you can use to change the world, and he showed the world how to change. And I would say that education is the only powerful tool, we have it in developing world, which is free of charge for the patients and effective if implemented. Thank you very much for listening. Thank you.
Thank you very much. Thank you, Dr. Abbas, for having such an excellent lecture. It was very nice to learn the various global approaches in order to reduce amputation and hospitalization. You very rightly pointed out that time is lost before the patient seeks specialized care, and the financial burden of foot problems in diabetes is vast. It is only the multidisciplinary team approach that will help us in cutting down this burden. Thank you very much, sir. I hand over the, we will have the discussions now. A big thank you to Dr. Banshi Sabu and Dr. Manoj Chawla for organizing this wonderful conference. We've had wonderful lectures this session, and we'll start with a discussion on each of the topics. Dr. Saxena, would you like to add something?
Yeah, it was a very wonderful lecture by Dr. Mandi. So, though you have cleared each and every point, which drug should be used at what stage of the disease, but for the interest of audience, just one question from my side. Sir, where do you place the use of SGLT2 inhibitors and Dpp4 inhibitor as a first-line therapy in your patient? And if so, what groups you use these drugs as an initial therapy, as a first-line therapy? Dr. Mandi, sir.
Thank you. Very good question. So certainly SGLT2 inhibitors, as I did emphasize, in patients with heart failure and in patients with chronic kidney disease, eGFR less than 60, or macroalbuminuria, I would use them as first line. There's no question there. Now the next is DPP4 inhibitors. Where would I use DPP4 inhibitors as first line? The honest truth is I really don't think I would use them first line in any situation other than in elderly patients where we need a small reduction in A1C and where it's more safety is more important than anything else. So say a 80-year-old with a A1C of 8.5, and I'm more concerned about safety, no comorbidities, early type 2 diabetes, no complications. That's where I would use a DPP4 inhibitor. So very select group of patients would I use it as first line in terms, and basically with an emphasis on safety and small reductions in A1C.
Thank you so much, sir. And one more question in this continuation as such, sir. Sir, where do you use this combination of SGLT2 and DPP4 inhibitor? As we all know that this combination covers the omnious octet of diabetes. So is it really wise to use in the initial phase of disease to slow the progression and to delay the beta cell failure, sir? And what is your usage, sir?
Okay. Let me clarify here. I think you all heard Dr. Ralph DeFronzo from San Antonio speak on the ominous octet and also speak on combining incretins with SGLT2 inhibitors. The real emphasis is using GLP-1 receptor agonists with SGLT2 inhibitors because the trials are showing cardiovascular benefit in terms of atherosclerotic cardiovascular disease with GLP-1 receptor agonists and combining them with SGLT2 inhibitors, which reduce the risk of heart failure, again, would be of tremendous benefit, both in terms of weight reduction, A1C reduction, both are pretty powerful in reducing A1C, as well as reducing the risk of cardiovascular disease and also in patients with heart failure. GLP-1 receptor agonists are safe. So certainly, in terms of preservation of beta cell function, again, yes, GLP-1 receptor agonists do preserve beta cell function from some of the studies we have. Although the RISE study, which looked at the combination of GLP-1 receptor agonists and metformin, showed you that once you stop the drug, beta cell function within 3 months goes back to baseline. But yes, there is data to suggest that GLP-1 receptor agonists preserve beta cell function, so I should not contradict my friend Dr. DeFronzo there. I think I agree. But at the same time, SGLT2 inhibitors may be preserving beta cell function also. Those were the initial studies with fluorescein that Dr. DeFronzo and Dr. Rossetti did in San Antonio to show that these drugs actually reduce glucotoxicity and improve insulin secretion as well as insulin sensitivity. So yes, probably combined together, these drugs do preserve beta cell function and are of benefit in terms of cardiovascular risk reduction. And lastly, combined together, reduce the progression of chronic kidney disease. I think that's most important, that chronic kidney disease progression is reduced by both these class of agents, both GLP-1 receptor agonists that reduce urine protein excretion, urine albumin excretion, and SGLT2 inhibitors that preserve renal function. So those certainly there I would use them. The unfortunate part is we don't have a single clinical trial showing initial use of SGLT2 inhibitors combined with GLP-1s in patients with type 2 diabetes. There's not a single trial. Again, it's not an easy study to design because you'll have to show either the 2 arms, SGLT2, GLP-1s, and then a combined arm. And again, getting additional benefit would require a large sample size, a large duration of treatment. So it's not an easy study, but I hope one day we would have that study, where you would use initial therapy with the two drugs, one from the GLP-1 receptor agonist class and the other from SGLT2, and look at outcomes, particularly cardiovascular outcomes and renal progression of chronic kidney disease.
Thank you so much, sir, for giving us a clear view that definitely if we see in the perspective of India, so being a very poor socioeconomic country, if the economic status of any patient permits and the patient is having associated cardiovascular disease and kidney disease with reduced GFR, these drugs are definitely going to benefit these kind of patients. Sir, any comment on oral semaglutide?
Yeah, oral semaglutide, again, we use it in the United States, but only in patients largely who don't want to inject. Our experience has been that it certainly reduces A1C far better than Dpp4 inhibitors. But in terms of weight loss, and particularly now that semaglutide 2 milligrams has been approved for use in diabetes in the United States, and the weight loss is fairly impressive, we would still prefer injectable semaglutide. The cardiovascular study with oral semaglutide really didn't reach significance in terms of MACE. So I think, if patients simply refuse to inject, then instead of using a DPP4 as an oral agent, I would definitely go with oral semaglutide. Yes, there is weight reduction and A1C reduction, but you got with 2 milligrams of semaglutide now approved, you got a pretty good weight reduction and A1C reduction right there.
Thank you, sir. Thank you so much, sir. And over to Dr. Manisha for any questions from your side.
I have a question too, and there's also a question from Dr. Kanan Natarajan, who's asked about your views on BCAA hypothesis in heart failure and benefits with EMPA. This is for Dr. Mandi Bajaj.
Yeah, so, branch chain amino acids, as well as, ketone bodies, all these are hypotheses, okay? We have no evidence in terms of actually infusing ketones in patients and saying ejection fraction improves, and so, unless you infuse some of these compounds and show in a clinical trial that there's an improvement. Now, one of my colleagues, Dr. Birnbaum, with whom we did a lot of these studies, says, well, the best way to do this is put them on keto diets and look at the benefit, if any, of ketones on ejection fraction. That would be a simpler study to do in an in vivo model. But again, these are hypotheses that aren't proven as yet, and so someone will go with myocardial metabolism. There's a lot of hypotheses, but very little proven in actual clinical trials, which are not easy to conduct. So unless these studies are done, we still say what we think is that these SGLT2 inhibitors activate AMPK in the heart. They activate AMPK in the liver also, and hepatic liver fat comes down. Similarly, they probably reduce myocardial inflammation, myocardial triglyceride. Again, no study to show us myocardial triglyceride pre and post treatment with these drugs, and thereby improve ejection fraction. Because what you're seeing here, whether it's a fatty liver or a fatty heart, the bottom line is that's a major problem in type 2 diabetes and obesity.
Right.
At the last of the session, I would like to thank all the speakers, Dr. Mandi Bajaj, sir, Dr. Abbas, and Dr. Graham for this wonderful deliberations. And we are thankful to all of you. And I would also like to thank our co-chairpersons, Dr. Manisha and Dr. Divya Saxena. So thank you all.
Thank you. Thank you very much.
Now we move on to our next session. That is the state-of-the-art lecture. And for this session, we have our two chairpersons, Dr. Manoj Chawla. I think sir soon, and Dr. Dharmendra Pachar from Ahmedabad. So over to you, Dr. Dharmendra Pachar.
Yeah, thank you, Dr. Snehal, for inviting me. And ladies and gentlemen, I welcome you all for the State of Art lecture. First lecture will be going to taken by Dr. Tirthankar Chaudhary. He is MBBS, MD, MRCP, FRCP, both London and Edinburgh. Postgraduate certificate in diabetes from London, specialist training in diabetes and endocrine from UK, senior consultant in diabetes and endocrine at Apollo Multispeciality, Kolkata. He has been examiner for MRCP UK. He has written book chapter on multiple book chapters in various textbooks, and he has on his name many publications. This will be a pre-recorded session. Would request RX team to please run the video.
Very good day, and I thank the organizers of Diabetes India for inviting me to speak this morning on a very interesting topic, ASCVD in type 1 diabetes. Now we must understand that our knowledge of incidence, prevalence, cardiovascular disease, and mortality is mostly an extrapolation of our knowledge in type 2 diabetes and cardiovascular risk. However, there is some fundamental difference between type 2 and type 1 in terms of ASCVD. In type 1 diabetes, chronic hyperglycemia, hypoglycemia, glycemic variability, along with the standard risk factor of dyslipidemia, hypertension, and even metabolic syndrome are important. But we have also understood that in type 1 diabetes, duration of diabetes, early onset diabetes, and women are more vulnerable. What is also interesting to know is that even in a good metabolic control, the chances of ASCVD in type 1 diabetes is twice that of general population. We have also seen from our experience and our knowledge of epidemiology of complicational Pittsburgh study that people who were born between 1950 to 1964 and those who were born between 1965 to 1980, it is the latter group that has the increased life expectancy of 14 years. Similar knowledge comes to us from Scottish data that tells us that type 1 diabetes loses a life expectancy of 11 years and 13 years for the men and women. So with this knowledge in the background, we are understanding the gray areas where the evidence does not essentially correlate with the outcome. However, we have got some evidence at the moment, both of clinical atherosclerosis and risk factor for preclinical atherosclerosis. If you look at the burden of type 1 diabetes, then it was 0.5% in 2016 in US adult population, but it has increased worldwide, and that is due to reduced natural selection and improvement in cardiac care or cardiovascular disease care and cardiac interventions. As I said, that Pittsburgh epidemiological study for diabetes complication shows that overall mortality reduction and significant improvement in life expectancy happened as our knowledge of cardiovascular risk factor and intervention increased. We still do not know that at what point in a child, or for that matter in a type 1 diabetes, to intervene with the cardiac drugs. We do not have enough evidence of their implications also in terms of long-term outcome. Total risk of CVD remains in type 1 diabetic patient more than non-diabetic patient. If you look at the data of 2016-17, and if you look at the mean age of population 28 to 44, then you see 16% had a history of CVD. You had 2% had a stroke. But if you look at the Indian data, then we do not have very good data follow-up in terms of what happened to the type 1 diabetes later on in terms of cardiovascular disease. There are some recent publications, of course, but what I'm referring to is that we have got one understanding that the risk of diabetes increases 3 to 18 times in type 1 diabetic due to cardiovascular disease in comparison to general population. Now the question comes, what happens if there's a chronic hyperglycemia? What happens is very simple, that when blood glucose or plasma glucose enters a cell, there is a stress of the endoplasmic reticulum. And this endoplasmic reticulum stress produces reactive oxygen species or oxidative stress. And they stimulate the cytokines and chemokines. And these in turn generate a cascade of inflammatory pathway, stimulating interleukin 6 and TNF alpha, etc., that ultimately lead to the endothelial dysfunction. If you look at the lipotoxicity or adipocyte, when there's too much of ectopic fat and the adipocyte gets hypoxic death, they also become a center of cytokines and chemokines. They also contribute to the inflammatory pathway and lead to the endothelial dysfunction. These are the studies that have made us wiser in terms of clinical atherosclerosis in type 1 diabetes. It talks to us about the ASCVD in terms of incidence. It talks to us in terms of prevalence, cardiovascular disease, and mortality. If you look at the Jocelyn study, they had a small number of patients, 292. But when they looked and followed it for 20 to 40 years, they had cumulative mortality risk, which is far higher than the general population. If you know the Wisconsin epidemiological study, they had got two groups. One was the younger age group, had almost 1,200 patients who were on insulin and diabetic. They had a greater risk. If you look at the right side, I will show you the data. If you look at the younger onset versus the older onset, then you will find the ischemic heart disease or standardized mortality ratio is far higher in the younger group, those who are on insulin less than 30, than on the older onset. If you look at the Pittsburgh epidemiological study, it was a cross-sectional study. Again, standardized mortality ratio was much higher in men and women in comparison to the general population. Eurodab is another study that tells you the CVD risk of 9 and 10% prevalence in men and women. But more interestingly, Eurodab also tells you that if you are between the age of 15 to 30, the risk of cardiovascular disease, the cumulative risk is 6%. But if you survive between the 45 to 60 years, it goes up to 25%. If you compare the EDC and Eurodiab, then what we find is that they actually match in terms of outcome. But when you compare the DCCT versus the EDC, the Pittsburgh Epidemiological Diabetic Complication Study, what you find is that the intensive control group is much better in terms of cardiovascular risk in comparison to the conventional group. What I'm trying to say is that Framingham study showed you CAD of 35%, much higher than the non-diabetic population. Pittsburgh epidemiological study again showed you that the incidence of major CAD, type 1 diabetes aged between 28 to 38, was 0.98% per year, surpassed 3% per year after the age of 55. Eurodab IDDM complication study, it shows that had 3250 number of type 1 diabetic patients, and prevalence was 9% to 10%. But if, as I said, that increased with diabetes at 6%, the CVD prevalence to 25% if they survive longer. UK General Practice Research Database is a good because they had more than 7,400 type 1 diabetic patients. And if they look at the mean age of 33 plus minus 14, the diabetes duration of 15 plus minus 12, reported that CVD events occurred about 10 to 15 years earlier in type 1 diabetic patient than non-diabetic group. So during a mean follow-up of 4.7 years, the hazard ratio was much more in terms of type 1 diabetic patient. If you look at DCCT addict, it is compared, as I said, the intensive group of DCCT addict had lower cumulative incidence of cardiovascular disease than conventional treatment group. So what was the difference? The blood sugar was better controlled, but was significantly higher in the conventional group, where the blood sugar was not so intensively controlled. If you look at the Swedish National Diabetes Registry, they also concluded that early onset, women, and poor glycemic control affected the outcome. Type 1 diabetes before 10 years. This was interesting. Those people who had diabetes type 1 before 10 years, they had the risk of 30-fold increased risk of CHD and AMI, and women displayed a 60 to 90-fold increase in terms of acute myocardial infarction. And of course, the women are affected more than men. And CVD prevalence depends on diabetic duration, glycemic control, age of patient included in the cohort. This has events happened 10 to 25 years earlier, ladies and gentlemen. So now we come to preclinical, subclinical atherosclerosis. The big question is, you have got a type 1 diabetic patient in a clinic. So how do you assess? What we say is that if you find an ankle brachial pressure altered, and if you find a coronary calcium scoring abnormal, then there is a reason to look at the luminal stenosis. So what are the parameters you are going to look? CIMT, that is carotid intima medial thickness, if it is more than 1 millimeter. If you do a coronary calcium score and it is more than 400, extensive evidence of CAD. Of course, 300 to 400 does not mean that they are not risk, but 400 is very convincing. And of course, coronary computed tomography and angiography, it is a confirmed study to look at the luminal stenosis. These can identify your patient at risk. I'm talking of preclinical atherosclerosis. However, as I told earlier, altered ankle brachial pressure or coronary calcium scoring is high is a reason for you to investigate further. Now, if you look at endothelial function is altered, even at a very early stage in type 1 diabetes, we know that. A meta-analysis of 90 studies confirmed what? That there was significant greater carotid IMT. And if you can do further these studies available, then endothelial-dependent flow-mediated dilatation was reduced. There was significant increased velocity between carotid femoral pulse wave, and there was decrease in the dilatation mediated by nitrates. These are some of the things that can give you an insight on a preclinical atherosclerosis in type 1 diabetic patient. I think it is very important reason to investigate and pursue our CVD risk in type 1 diabetes, because we know that you can actually prevent and postpone death. The pathophysiology, as we know, the etiopathogenesis, factors in type 1 diabetic patient. There are conventional risk factors, hyperlipidemia, hypertension, smoking, etc. But we also know that there are hyperglycemia, hypoglycemia, glycemic variability, metabolic syndrome, insulin resistance, albuminuria, age, gender, duration of diabetes, and even exercise. I want to remind you about the Steno type 1 risk engine. If you look at the Steno type 1 risk engine for type 1 diabetes, a CVD risk, then you know that they take into consideration your HbA1c, they take into hypoglycemia, they take ethnic origin, they take your even exercise, alcohol, so age, gender. So they are quite comprehensive, and they actually estimate the risk better. Now, if you look at hyperglycemia, as I said earlier, that oxidative stress, protein kinase C activation, non-enzymatic glycosylation, these are important, and even 1% risk in HbA1c is associated with 6.4 increase in terms of coronary stenosis. The risk of death from CV causes in type 1 diabetes with HbA1c less than 6.9 is twice that of normal population. That makes you worry that even in a good metabolic control in type 1 diabetes, you have got twice the risk of death in terms of cardiovascular disease. But if you have got more than 9.7, then you are at risk of 10 times. Therefore, it is important that we understand that we need to intervene very seriously. And we know that the 17 years follow-up of the conventional group, we know versus the intensive group, you can reduce the CV events, you can reduce non-fatal MI, and the combined endpoint of stroke, MI, CVD can be reduced. Hypoglycemia, as we all know, can cause subclinical inflammation, endothelial dysfunction, thrombosis, ischemia, autonomic dysfunction, arrhythmia. Effects can promote atherosclerosis, cardiac ischemia, and cardiac repolarization. But what we don't know is that what is the exact correlation between each of them to the generation of ASCVD or as a risk factor for ASCVD in type 1 diabetes. But what we know for sure is that the recurrent hypoglycemia is established as a cardiovascular risk. Therefore, it is important to prevent hypoglycemia. And average type 1 diabetes, as you know, even if you leave aside the brittle diabetes, have average 2 minor hypoglycemias per week or even in 2 weeks. So we need to get the CSE score done and be more aggressive. Insulin resistance and metabolic syndrome, if you look at the DCCT study, demonstrated that intensive therapy was correlated, and excessive weight gain, this is in comparison to a general thought that all type 1s are thin. Insulin-treated intensive group did show evidence of metabolic syndrome and insulin resistance. Abdominal obesity is independently associated with CV complications that we already know. Lean type 1 diabetes present more insulin resistance than matched control subject. These are some important issues that we know. Dyslipidemia, this is our, as we know, is a standard conventional risk factor. Now, important is that how do you treat? Thumb rule is that anybody who is having an LDL less than, should be have an HbA1c less than 100. Now, any atherosclerotic risk should have less than 70. We also know that ADA tells you somebody who is over the age of 10 years and has no atherosclerotic risk factor, you should wait till 160. But of course, any atherosclerotic evidence less than 100, I think it is very important as a thumb rule to keep it below 70. And if it's more than 10 years of diabetes, then of course you can classify them as high risk, moderate, or at risk. Hypertension, again, our aim is to keep less than 140/90. Ideal should be probably 130/80. But a lot of studies, Eurodiab and DCCT has all shown that a good blood pressure control can affect the outcome. Diabetic kidney disease, as we know, the albuminuria is the first evidence of endothelial dysfunction. Therefore, after 20 years of disease duration, 29% of patients with childhood diabetes and nephropathy will present future CAD. So microvascular complication is a risk for macrovascular complication. So if we find somebody with albuminuria, then we should be very alert in terms of the cardiovascular risk. CVD prevention in type 1 diabetic patient, hyperglycemia, hypoglycemia, glycemic variability. CVD prevention in type 1 diabetes, maintaining optimal glycemic control in long term is mandatory, and disease decrease the macrovascular event, short diabetic duration, no previous CV event, and long life expectancy. A target of achieving HbA1c less than 70 is appropriate with the advent of course, insulin pump, multiple insulin injection. We can actually do a better glycemic control. More type 1 diabetes should be treated with intensive insulin regimen. We still unfortunately find that both monitoring and insulin regimen are less than expected. If you look at the dyslipidemia treatment, then of course there are guidelines you can go through. But of course, as I said, my thumb rule would be less than 70, but without atherosclerotic complication, maybe 100. Maybe children and adolescents have some more leeway, and you can go up to 130. But any evidence, they are often classified as high risk, moderate risk, and low risk. And in heart protection study, again, of course, lower age limit. And what they say is that if you have got type 1 diabetes, a reduction of risk that is proportionally similar to type 2 diabetes. And of course, in a prospective cohort of type 1 and no underlying CVD, lipid lowering theory was associated with decreased all-cause mortality. Recommendation, ADA guidelines, as I said, were less aggressive, but undoubtedly thumb rule is to keep it less than 70. Recommendations, you can go through an ADA, but both for blood pressure and statin, tight glycemic control, avoid hypoglycemia is what should be done. Type 1 is associated with 3-fold higher mortality rate, CVD is a major cause of this mortality. CVD risk remains high even in well-controlled type 1 diabetes. Lifestyle intervention is important. There are concerns about CVR stratification. And of course, there are further research needed to clarify factors in premature CVD in type 1 diabetes. Elucidate efficiency and age in which current CV medication should be used and novel cardiac drugs. Just to leave you with a thought for my clinic patient who is a type 1 diabetic for 30 years, BMI 23, HbA1c 7.6, LDL-C 92, TG 256, albuminuria, and on insulin pump. Now, Steno type 1 risk assessment is 10 to 20%. Therefore, I leave you with the thought of how aggressive you should be. I think investigation for luminal stenosis, better glycemic control, less hypoglycemia is my target. Thank you very much.
Thank you for the session. Dr. Tirthankar is here. Sir, we would like to take the question at the end of the session, and we will move towards the next session, which is going to be taken by Dr. Anil Boraskar. Dr. Anil Boraskar, sir, will speak on obstetric sleep apnea and diabetes. He is an honorary secretary, scientific section, Diabetes Association of India since 1984 till date, member, executive managing council, Diabetic Association of India, member, National Academy of Medical Science, fellow of Royal College Physician London, retired chairman-elect of Southeast Asia region of IDF. He has been running his clinic, diabetes care in Mumbai, practicing since last 35 years. He has been honorary associate professor of medicine in Grand Medical College for 15 years, honorary professor of diabetology at All India Institute of Diabetes, Raheja Hospital for 13 years. He has been scientific secretary of Diabetic Association of India in many paper publication, oration, and what we need to learn is the wisdom from him. Over to you, sir.
Thank you very much, Dharmendra. Now, this presentation is going on for many years, and I was the one person who introduced this about 20 years back, that there is something known as obstructive sleep apnea, when people even did not know what it is. The point is that we saw many cases, you could not explain many symptoms. Next slide, please. And many symptoms, next slide. Yeah. So what is obstructive sleep apnea? Repeated, partial or complete obstruction of the upper airway during sleep. It's a highly prevalent disorder which affects severe body systems. The most dangerous complications of the untreated OSA primarily include three body systems: metabolic, cardiovascular, and CNS. Now, you see, it's such a common thing that people are used to somebody snoring very loudly enough that, in fact, there are many divorce cases are filed because of snoring. But they never thought that snoring can have such a pathological effect. And all big snorers are not necessarily obstructive sleep apnea. And all obstructive sleep apneas do not snore loudly. You see, so you cannot really say that the snoring is the indicator of a OSA. Next slide, please. So snoring is such a common phenomena, and particularly with the abdominal obesity and type 2 diabetes in India, snoring becomes a normal phenomena. Next slide, please. Yeah. Now, signs and symptoms are very important. Now, please pay attention to this. Excessive daytime sleepiness. Now, excessive daytime sleepiness in a big seminars like this is largely due to boring lectures. Loud snoring. Observed episodes of breathing cessation during sleep. Now, this is very, very important. The spouse comes and tells you, sir, he starts snoring, and suddenly he stops snoring and he just chokes and gets up with a frightening phenomena. So this is a bad thing, because that is a stage of apnea. There is a hypoxia. Abrupt awakening accompanied by gasping or choking, awakening with a dry mouth and sore throat, morning headaches, difficulty in concentrating during day, experiencing mood changes such as depression or irritability, high blood pressure, nighttime sweating, and decreased libido. Now you understand these symptoms are so common. All these symptoms are seen in chronic alcoholics. All these symptoms are seen with a chronic drug abusers. All these symptoms are seen by people who are undergoing a lot of stress, balance sheets, March end, people are trying to do a lot of adjustment, they can't sleep, lot of calculations. But if it is associated with the obstructed apnea, it's a serious matter. Next slide, please. Risk factors. What are the risk factors? Common as is obesity, increasing age, endocrine and metabolic, male genders, anatomical abnormalities of the upper airway, family history of sleep problems, alcohol and sedative use, and smoker. COPD, chronic smoker, chronic asthma, chronic obstructive lung disease. These are all risk factors. Next slide, please. What are the complications? There are 4 groups. Metabolic, cardiovascular, behavioral, and others. What are the metabolic? Most important, insulin resistance. Insulin resistance and elevated fasting hyperglycemia is a consequences of poor sleep, weight gain, nocturia, sexual dysfunction. Cardiovascular, many hypertension, rhythm abnormalities, atrial fibrillation, particularly left atrial enlargement, cardiovascular events, myocardial infarction in the sleep, and heart failure. Behavioral, cognitive, and memory problems. Many people, they say, I have not had a fresh sleep. I really didn't get a sound sleep. And somehow, what you're telling me in the morning, I can't really comprehend. I cannot understand. Can you repeat it again? Even if you repeat it, he has a failure to understand. He says, when I try to read newspaper, I don't understand half of the things. I said, that is a normal pattern of newspaper. If you are wise, you will not read newspapers. All newspapers give confusing picture, confusing reports, but a sound person who's normally used to taking classes in the morning, he likes to brush up his academic tips. He says, I read it yesterday, somehow it's all confused. I said, did you sleep well last night? I said, that is a problem. Now, that's another thing, concentration difficulties. Now, concentration, in certain cases, your new learning process need a lot of concentration. Particularly new biochemistry, biophysics, synaptic junction, suprasynaptic, infrasynaptic, presynaptic, membrane transmission, to all this read, and all the modern pharmacotherapeutics, when you try to read, particularly to teach the students, you feel, sir, this is a naya kuch samajhta nahi hai. Ye samajhta nahi because you are not slept well. And that's why people say, you better sleep over it. ये जो है ना सब चर्वी चरण मंथन कर रहा है, you have a good sleep in the night and tomorrow morning you come and maybe the things will become very clear. So when the idiom is that to sleep over a problem, the problem becomes simpler. And others are excessive daytime sleepiness. And this is, believe me, this is a major cause of vehicular accidents in the United States. Huh? Daytime somnolence and nighttime insomnia. The drivers fall asleep, the truck drivers fall asleep while driving long distance. That's why now the highways are constructed that every 10 or 15 miles, they have kept a bump. So the bumper wakes you up in case you fall asleep. The Chernobyl, the atomic reactors accident and a space shuttle, the Challenger, the accidents were due to excessive sleepiness. Fatigue-related accidents and headaches. If somebody is complaining of constant headaches, there are two problems. One is number exchange, he's got a hypertension, and interrupted sleep. This is a cause of OSA. Next slide, please. Now, type 2 diabetes, what causes what? The cause and effect relationship, whether it's a bidirectional, whether OSA causes type 2 diabetes causes OSA. Let's go to that. Next slide, please. A number of studies, including longitudinal studies and meta-analysis, show that OSA is a risk factor for type 2 diabetes, independent of obesity and other risk factors. Independent, a thin fat Indian can also develop OSA, and that is a cause of type 2 diabetes. Next slide. Does diabetes lead to OSA? Yes. Meta-analysis has confirmed that the moderate to severe OSA is associated with greater risk of diabetes when compared with the absence of OSA. Next slide. The relationship is bidirectional. It is interesting that both OSA and type 2 diabetes are associated with a similar comorbidities, some of which include hypertension, CVD, dyslipidemia, and chronic kidney disease. Many of the ongoing trials are focusing on whether having both OSA and type 2 diabetes is associated with greater severity of a comorbid conditions compared to either one of them. So this is a very important study. The effect of OSA on type 2 diabetes. What is the effect? Next slide. Several cross-sectional studies have demonstrated a link between OSA and poor glycemic control, such as HbA1c, fasting glucose is high, variation in plasma glucose level, glycemic variability increases following adjustment for several confounding factors. Next slide. The severity and insulin resistance. Punjabi is a person who has won a lot of work, demonstrate that metabolic consequence and community prevalence of sleep disorder breathing after adjusting for BMI and percentage body fat. The increase in HI was associated with a worsening of insulin resistance independent of obesity. OSA is an independent risk factor. Southeast Asia study in Malaysia also concluded that insulin resistance and OSA. Next slide. Other study, approach towards the patient with type 2 diabetes and OSA. How do you approach? Obviously, weight reduction is the primary thing. History taking, analysis of signs and symptoms of OSA, analysis of risk factors, examination of upper respiratory anatomy, particularly your adenoids, your upper pharynx, whether the tongue falls behind in the sleep. All this detailed analysis you must do. Next slide. Lot of importance to BMI. Diagnosis, very simple, type 1 diagnostic. Study a hospital lab. There are 12 lead EEG. It is costly, cumbersome, requires hospital stay for one night, requires a source-rich setup to conduct the study. But usually it gives you a lot of information about what is happening to his hypoxia, what is happening, the effect of hypoxia on the brain, what happens to alpha wave, beta wave, zeta wave, which is 12 lead EEG of the brain. That is the most expensive part in hospitalization. But the same thing can be duplicated at home, known as apnea link study, which can be done at home. Next slide. And that is quite practical. Next slide. Type 3, home-based cardiorespiratory monitoring diagnostic. 4 to 7 channels are increasingly used in practice by American Association of Sleep Medicine, as well as IDF has approved this. Next slide. It's a small calculator-like thing. Apnea link air study in diabetes patients. The IDF recommendations, screening people with type 2 diabetes for OSA. The screening study used in which structure questionnaires stop bang. It's a structure question. It's a very important questionnaire that you have to answer. And answers almost 50% diagnostics. Next slide, please. The question is very simple. In a simple language, it is written. And a person spends some time, he virtually gives you a diagnosis. Next slide, please. How do we measure? Now, AHI is apnea hypopnea index. There is apnea means total cessation. Hypopnea is a low number of oxygenation. 0 to 5 normal, 5 to 15 mild apnea, 15 to 30 moderate, more than 30 is severe. They need machines. Next slide. Treatment. Cpap is a gold standard treatment, I would say. Cpap is continuous positive pressure breathing. Along with Cpap, lifestyle modification, sleep hygiene, weight loss should be advised in all patient type 2 diabetes. Some other treatment options are dental appliances, surgeries in selected group, conservative measures such as alcohol cessation, smoking cessation, mild nasal decongestant so the nasal passage is open and you are able to breathe. Next slide. This is how the function of continuous positive airway pressure or a CPAP to put a nasal cannula, or there is something known as nasal pillows. You don't have to wear a mask, which is frightening. There are some nasal pillows, they give you a positive pressure adjusted to your requirement of inspiration, expiration. There are autopaps, there are biovibes, and these are all self-adjustment machines available very nicely and definitely improves the quality of life. Next slide. Now these are the models. This is the most latest model. That is a bi-level. This is commonly used, automatic CPAP machine. And this is a CPAP machine which is not variable pressure. This varies the pressure according to the obstruction. If the obstruction is less, it reduces the power of pressure. If obstruction is more, it increases the power. Next slide. Effect of CPAP on type 2 diabetes. Next slide. It reduces risk of incidence of type 2 diabetes. Incidence also comes down. Next slide. Treatment improves HbA1c. Definite improvement after CPAP. Next slide. Effect of CPAP on diabetes control. HbA1c fasting, plasma insulin and insulin resistance. Clear-cut evidence. Next slide. What about the diabetes complications? OSA is independent risk factor for hypertension and non-deeper phenotype BP. What are the non-deeper BP people? In the night, when you sleep, your BP must come down. We call it dipping. This dipping effect is not seen in diabetics. The night systolic pressure is 160. It doesn't come to 120. In type 2 diabetes, OSA treatment with CPAP has shown to reduce the mean arterial pressure, systolic blood pressure, and a diastolic blood pressure. There's a beneficial effect in hypertension management in diabetes. Presence of OSA show to increase the risk of stroke, coronary artery disease, and MI, and heart failure. CPAP has shown to delay or prevent the occurrence of CVD. Next slide. Microvascular complication, retinopathy, nephropathy, neuropathy, they all seem to be delayed, and some of them are even treated by use of CPAP. Next slide. Next slide. So, friends, I'm not here to promote the sale of CPAP machines. I don't have any agency or I get any cut from the company. But it is one single tool. In my case, I am a person who had a very severe sleep apnea. And I got everything making, means I am a home wicket for CPAP. I was weighing 123 kilos. Today I am 105 kilos. I lost 15, 16 kilos weight by sheer hard work, exercise and dieting. After that, my apnea has definitely come down. I hardly need to use the machine. My oxygen saturation improved. My quality of life is improved. I am a lot more approachable. by my patients. I don't shout at them in the morning, early morning, late night. My students are quite happy with me because I don't scold them and I don't talk sarcastically, although they are a bunch of idiots, many of them. And I have developed enormous patience with everybody because I'm in complete state of peace to myself. I'm in a state of tranquility without any tranquilizer, without any alcohol, without any sedative, and only because I'm sleeping well, I'm breathing well, and I'm exercising well. There are three integral parts of health: exercise, nutrition, and rest. To follow these three patterns, you will not need a single medicine. Neither ACE inhibitor, not statin, not aspirin, nothing. But these are the features you do it seriously. One of them is sleep. Sleep is God's greatest gift to mankind. And that, if it is assisted with a tool without medication, what more do you want? Thank you very much.
Thank you, sir. And as I said, that's the wisdom we need to learn from Sri Boraskar, sir. Moving ahead to the next session, we do have Dr. Michael Hermann from Germany. He's going to speak on effect of lipid-lowering drugs and types of statin on SARS-CoV-2 infection and severity in diabetes. Dr. Michael is a senior consultant at St. Luke Academic Hospital, Brussels, and he has won the prize from Association of which do diabetes. He's a visiting fellow, Diabetes Research Laboratory, Oxford University. Desk is yours, Dr. Michael.
Thank you. Good morning, everyone. I will try to share my screen. So my topic today, I hope you are seeing my screen.
Yes, sir. Your screen is visible.
Excellent. So thank you very much for inviting me to share with you some results. This is a local study that we did in Brussels on trying to phenotype patients who became infected with SARS-CoV-2 and also to better precise the phenotype of diabetic patients who got severe forms. So this is a single center academic study, but we found some interesting results that I would like to share with you. So here are my disclosures. So as you all know, since the beginning of the pandemic, diabetes has been considered as a risk factor for severe COVID-19. But there is, on the other hand, no evidence that the fact of being a diabetic increases the risk of contracting COVID-19. Now, what is very confusing is that when you look at it, the two major risk factors for type 2 diabetes are the same as the two major factors for severe COVID, which is namely age and obesity. And the other problem is that factors predisposing to becoming infected or having severe COVID are usually subject to generalization that do not take into account the type of diabetes. And this is why we embarked on a study of both type 1 and type 2 diabetics to see what was common or specific to the different types of diabetics. And also, as you may know, because age and obesity are themselves contributing to affect glycemic control, especially the more obese you are, the lesser glycemic control you have. This is very confused and intricate. So what we did was to document the phenotype just prior to infections of a very well phenotyped cohort of mixed type 2 and type 1 diabetics that we saw over slightly more than 2 years, and then to analyze subgroups of specifically type 2 and type 1 patients. That's for the part becoming infected, and that we did the same for having severe COVID, analyzing in the global cohort of a mixed type 2 and type 1, and then in subgroups. Now, already here, we were not able to analyze a subgroup of type 1 diabetics with severe COVID because there were too little. We only got 5 patients with severe COVID with type 1 diabetes, so we couldn't even do that analysis, which itself is interesting. Altogether, we included 934 consecutive patients, about 2/3 of type 2 diabetics and 1/3 of type 1 diabetics. So here are the characteristics. If we take the overall cohort, I don't know if you see my arrow, but I hope you do. Overall, we got 20% of the overall cohort who became infected. And among those who became infected, another 20% got a severe COVID-19. Now, we define severe COVID as being admitted to hospital and or a death from COVID. The study lasted more than 2 years, so over time, increasingly more patients became vaccinated. We had, as I told you, 2/3 of type 2 diabetics, 1/3 of type 1. The majority was white Caucasian, but we had substantial ethnic minorities from Africa, especially North and Black Africa. Those who became infected were usually younger. This is usually found in all studies. We had no difference in gender. We had no difference in type of diabetes, but we had a much less prevalence of white Caucasians who became infected, since ethnic minorities are known to be more at risk of becoming infected for various reasons, most of them being behavioral, probably. Now, the other characteristics of those who became infected, they had a higher BMI, which has not been well explained. Usually, the more BMI you have, the more risk of becoming infected you have. Because they were younger, the GFR was better, and they were less often taking statin, which may be related to their younger age, and a slightly less prevalence of macroangiopathy. But I will come back later on those statins, because this is the topic of the talk. So that difference in statins was seen even if we correct it for secondary or primary prevention. So they were just less often on statin. Now, when we look of those who became infected by subgroup, first the type 2 diabetics, what we found that, again, they were slightly younger by an average of 3 years. And here we have a more precise difference in statin use. So the overall statin use was 10% lower, but what was striking was the discrepancy among statins, with a much higher use of atorvastatin and a much lesser use of rosuvastatin. I haven't shown all the details, but the proportion of high-intensity statin was about the same as was what we call the statin equivalent dose, which is a normalization of any type of statin to atorvastatin equivalent. There was no difference in macro or macrovascular disease in those patients who became infected. What about the type 1 diabetics who became infected? Again, they were younger, this time by an average of 7 years, and hence their prevalence of macroangiopathy was much lower. Otherwise, there was a non-significant different use of atorvastatin, which was higher as in type 2 diabetics in those who became infected. Now, if we look at those who develop severe versus non-severe in the overall cohort, 2/3 diabetic, 1/3 non-diabetics, we just found everything that was reported. So being older by an average of 14 years, having type 2 diabetes, which of course is related to being older, having a higher HbA1c and a higher BMI, also a body composition with more central fat, as measured by waist circumference or percentage of visceral fat, being hypertensive and blah, blah, lower GFR. Everything was significant except for the gender difference. There was no gender difference having severe versus non-severe in these patients, which is usually less the case in non-diabetics, in whom male gender is more affected with the severe forms. And as regard macrovascular disease, there was no difference in macroangiopathy. Otherwise, look at heart failure, it just exploded, as well as atrial fibrillation. Well, all those conditions also tend to increase with age. If we look now at the type 2 who had severe versus non-severe forms, of course, the numbers are lower, so some of the significances will disappear. But what we found was, again, a difference in age, but only of 6 years on average. Less glycemic control, less good glycemic control, which I consider is probably just related to those patients being more obese and fatter. It was still significant for visceral fat. Those patients had more abdominal fat. They were more hypertensive, and their GFR was lower, which is likely a result of age. Again, heart failure was evident as a condition raising risk of severe forms, as was well known from non-diabetics. What about the levels of lipids? Well, there was no significant difference in LDL cholesterol in both the combined cohort or the only type 2 cohort, since, as I said previously, we had too few type 1 diabetics with severe forms in order to conduct a meaningful analysis. They were mostly characterized by having more atherogenic dyslipidemia. Of course, those patients with severe forms were more obese, so it was not a surprise. They had smaller LDL, a lower level of HDL cholesterol, which has been suspected to be also involved in virus transmission and infectivity. HDL may be protective against COVID infection, and they had much more triglycerides and atherogenic dyslipidemia. So that was not really a surprise based on their phenotype. What we found, which was very odd indeed, was their use of specific statins. As I told before, there was no difference in statin equivalent dose normalized to atorvastatin. They were taking 21 milligrams in the non-severe and severe form, so exactly the same amount of statin, and a non-significant difference in high-intensity statin. It was not significant, but severe form patients were even having more high-intensity statins. But what was striking us for becoming infected was the much higher use of atorvastatin in patients who developed severe forms. This is the mixed cohort type 2 plus type 1, and a much lower use of rosuvastatin prior to getting SARS-CoV-2 in those patients who had the severe forms. What about ezetimibe? Again, there was a mismatch. Ezetimibe with or without statins was much lower used in patients who developed severe forms, as was the combination of any statin plus ezetimibe. On the other hand, the ezetimibe as a monotherapy was associated with severe forms, but the numbers were extremely low. Finally, fenofibrate, which is used to treat atherogenic dyslipidemia, was unsurprisingly much more used in patients who developed severe forms, likely a result of their AD. If we take specifically the type 2 diabetics with non-severe versus severe forms, again, we found that very odd and unexpected mismatch of high-intensity statins with the severe forms. This is only type 2 diabetics now, being more than twice often more used in those with severe forms, and rosuvastatin being almost exclusively used by those patients who developed non-severe forms, with again the same standardized equivalent dose of statins, but even a higher use of high-intensity statins, which is of course atorvastatin in this case, for those patients who developed severe forms. And again, ezetimibe use was much lower in those patients who developed severe forms. So if I summarize, for becoming infected, we found that a combined type 2 plus type 1 diabetic patients cohort is less often on statin just prior to infection. Specifically by subgroups, infected type 2 diabetics are more often on atorvastatin when they become infected, and less often on rosuvastatin. The difference, if you combine both difference, is huge. In type 1 diabetics, there was no difference in statin use at the time of being infected, but still there was a non-significant higher use of atorvastatin in those patients who became infected. If we move to the severe versus non-severe COVID-19, what we saw was, despite a similar percentage of severe COVID patients being on statins compared to non-severe patients, and with the same statin equivalent dose, and a non-significant different percentage of high-intensity statins, the patients who developed severe COVID were more than twofold more often atorvastatin. And for those who had non-severe forms, they were more than 4 times more often taking rosuvastatin. In relative terms, it was 434%. Ezetimibe with or without statins was also much lower in use in patients who developed severe COVID, was the combination of any statin plus ezetimibe. Now, I haven't put a hypothesis because the high-intensity statin proportion and standardized equivalent dose is similar. It's unlikely to be simply due to difference in statin use. Also, the difference remained when we did some other analysis, a univariate analysis, but if we look at primary versus secondary prevention patient and all those stuff, all the difference remains significant, and we at current level do not have any explanation for that. Thank you very much for your attention.
Thank you for your nice session. It was really insightful and something new which I think we came across. Any comment from our expert speaker for this observation from Dr. Michael? Dr. Buraskar, sir.
No, I quite agree with him, actually. You know, we see this kind of variation many times. And at times there are many issues while you get this phenomena in type 1 diabetes. This is not something new to us.
Okay, fine. We have a question for Dr. Tirthakan Chaudhary, if he's there. Yes, sir is here.
Yes, please.
Yeah, sir. Just for type 1 diabetic patient, for the screening of atherosclerotic cardiovascular disease, do we recommend at what duration for the coronary artery calcium score, any guideline for that?
As I was saying, that the risk of atherosclerotic cardiovascular disease in type 1 is real, and they come quite early, and the risk is very high. Therefore, anybody over 10 years, unless you have got definitive existence of clinical manifestation of atherosclerotic cardiovascular disease. That's why I separated the group between if you are having a patient who do not have clinical evidence of ASCVD and patient who is preclinical. There are anybody over 10 years, and we do normally an altered ankle brachial pressure. And if you can do a CIMT, which is not very difficult, intima medial thickness, and if it's more than 10 years, and if he has got other evidence like microalbuminuria, so you clinically evaluate the patient. But if you tell me, when do you become proactive? Anybody who is a woman, anybody who has got it a long duration, maybe before the age of 10, and even if you do not have any symptoms, post 10 years, I would be interested in doing an intima medial thickness or coronary calcium scoring, or look clinically at least an ankle brachial pressure and look at the risk factor like lipids. I would look at microalbuminuria, look at retinopathy. And if there is the evidence of microvascular complication, that is an independent risk factor for macrovascular complication. Therefore, I would investigate. So 10 years if it is a thumb rule, but you must remember that if there's any evidence prior to that, you should look into it. But beyond 10 years, risk keeps increasing. So I would investigate preclinically. Thank you.
Thank you, sir. One question to Dr. Buraskar, sir. Just want to understand role of melatonin for the better sleep. Is it really, or what is the role of melatonin as a drug for the better sleep? Because we have seen quite across few prescription from our neuro colleagues also. So what's your take on for this? And
I prescribe melatonin very routinely. There is a lot of evidence, I think during COVID time, the altered sleep pattern, they particularly said that melatonin helps in COVID-related sleep disturbances. And we start with 0.3 milligram, 3 milligram melatonin, you can go up to 6 milligram. It has very little effect on the respiratory depression center. So melatonin is quite safe. My point is that there are phases of sleep of N1, N2, N3. Now, out of which N1 is very important when a patient is about to fall asleep. Now, if you want to cut it short, how to reduce N1? There are drugs for that. Melatonin helps there. Sustaining the sleep of N2, N3 pattern, the drug of choice is Ativan or lorazepam. But it may have a offshoot phenomena, means it may act little longer, and then a person may have a mild hangover effect. That effect is not seen in melatonin. Melatonin you can go up to 6 milligram also, no problem. And it is reasonably safe drug. I give it to many of my patients. They don't have any complaint about melatonin. It doesn't cause dryness of mouth. It doesn't cause any cognitive dysfunction next day. It has got no effect on the dreams. At least nobody has complained of bad dreams. And it has got no definite effect on altered breathing pattern. The sleep apnea doesn't become worse with melatonin. So I have a good experience with melatonin.
Thank you. Thank you, sir. Now we do not have further questions. So would like to thanks all our respected speakers and audience for having here and sharing their knowledge. Thank you all, and would like to hand over the session to the organizer for further. Thank you.
Thank you very much.
Thank you.
Thank you, sir, for the wonderful session. And next, we are move on to the very important lectures, keynote lectures by the eminent world-class speakers. Two speakers we have. For this, we have two eminent chairpersons, Dr. Jyoti Dev and K.S. Dev, and Dr. Lily Rodriguez. Over to chairpersons. Dr. Lily.
Dr. Lily was there. She has.
I couldn't able to see them and Dr. Lily. Anyhow, it's a great pleasure and pride and honor to introduce our first speaker, Professor Philip Holm. He's a past president of IDF Europe. He's a past vice president, International Diabetes Federation, and he's an emeritus professor, Diabetes Medicine at Newcastle University. He is going to enlighten us on the future insulins. Welcome, sir.
Okay, but I have a message saying you cannot screen share while other participant is sharing. So I can't put my lecture up.
RXT?
Yes, and now
yes.
You can share it.
Please.
Let's try it again. Okay.
Yes, sir.
That looks okay. Thank you. Yes, and thank you for inviting me again to the organizers to speak to Diabetes India. Been doing so now for a long time, it seems, and it's always a pleasure to speak to you. This year, I have 30 minutes to talk about the future of insulin therapy, and it's the future of insulin therapy in its second century. How am I going to address this? I addressed a similar topic last year. On this occasion, I'm going to talk about overcoming the technical barriers to insulin therapy, using the ideas that are current and being published in the last few years, and indeed this year as well. So what are the barriers and how are they overcoming them? I do have, of course, dualities of interest in regard of insulin products, but they don't apply to any of the products I'm going to talk to, largely because these are unlicensed things and things which are not on the market as yet. I published last year a couple of articles, more than a couple, 3 articles there on insulin reviews. The first one is the backward-looking review, the last 100 years, as it were. And last year I talked a bit more to insulin therapy development beyond 100 years. So this year it's based on the metabolism article, Future Directions in Insulin Therapy. I have, of course, updated the technical searches to this current month. If we think about the physiological need for insulin, then this, of course, should be what's determining the nature of the technical insulin we give to patients who are insulin deficient. And the most important, perhaps, is the minute-to-minute, perhaps minute-to-5-minute regulation according to changing need. So obviously, without thinking about it, we vary our insulin secretion according to what we're eating and according to our physical exercise. And we vary it enormously, as we'll see, by a factor of 10 or more. Secondly, there is a fast reflex, partly neurological reflex, and incretin response to calorie consumption. You only need to look at food and you begin to secrete insulin in greater quantities. And that, of course, importantly, is not glucose regulated. Then we have the glucose and amino acid regulation after eating and in the basal state. And these 3 things I've talked about all occur very quickly and are regulated, as I say, on perhaps a 3-minute basis. Then there's the slower regulation, the regulation that occurs within day, hour-to-hour regulation, according to changing need. And this occurs post-exercise when we become more insulin sensitive, post-hypoglycemia similarly, with concomitant illness and indeed other physiological stress, and in reflecting our overall calorie intake the previous day. And lastly, and more simply, we have a flat basal insulin delivery, except in the post-absorptive state. Now, presently, except for basal insulin delivery, we are unable to provide any of these with our current insulin therapy. And that accounts for the finding that with type 2 diabetes, no one attains normoglycemia in the sense of all postprandial on all-day plasma glucose within 4 to 7.5 millimoles per litre. And indeed, a tiny minority of people with type 2 diabetes indicated for insulin get to this range all the time either. Indeed, if you look at the average daily plasma glucose taken from clinical trials with intensive management, it's about 50% higher than normal, and we know those glucose levels are toxic. So just a reminder of the physiological profiles from non-diabetic people. In the basal state here, glucose concentrations in blue are absolutely stable overnight, somewhere a little above 4 millimoles per litre on average, and with very little variation. That's achieved by a flat and unchanging, if normoglycemic, insulin secretion. And you can show that with C-peptide as well as insulin. Then, if we look at the mealtime profile, there's this enormously quick rise in concentration. Remember, the insulin space is some 15 liters. So to fill that to 60% in 15 minutes requires an enormous output of insulin from the islet B cells. And from the peak at around 30 minutes, there's a decline to baseline again at around 4 hours. What this doesn't show you, of course, is that this is all regulated and it's made very precise to achieve this very tight glucose control, even after meals. Look, the peak is occurring at less on average than 7 millimoles per litre, and it's back down to basal levels by 2 hours. Far from a peak at 2 hours, we're back to basal at 2 hours in the physiological state. And that's done, of course, because glucose levels are toxic. Furthermore, the incretin response, nothing to do with measurement of glucose levels, is very large. If you take insulin secretion and you match the glucose levels for an oral glucose level with intravenous glucose, you only get a third of the insulin output, meaning 70% of the insulin output after a meal is actually incretin regulated rather than glucose regulated. And this means our attempts to regulate insulin by glucose are intrinsically flawed, unfortunately. So within 5 minutes, then we have regulation according to our reflex calorie intake, according to our physical activity. If I was to run outside at the moment, I would drop my insulin secretion in 5 minutes, and according to acute stress. And in a few hours by these other things, including, importantly, exercise and hypoglycemia. It's interesting that the closed loop community, in order to imitate this, has, of course, depended on trying to measure glucose. And trying to measure glucose is fine, it's important in the basal state, but it's impossible as a control at meal times. So these are hybrid systems where you actually prime your mealtime insulin secretion, as marked by the little green triangles, manually. But even then, in order to get tight regulation, they have to make the algorithms very sensitive. And you see the effect of that is far from a basal continuing insulin secretion. You get these square wave humps. The system is hunting, in fact, to try and achieve some kind of glucose control. But even during the night, it's not controlling glucose levels anything like to below 5, and certainly not even below 7. So these closed loop systems are currently not getting normoglycemia. And this is why the time in range that they've chosen goes up to 180 milligrams per deciliter, 10 millimoles per liter, and not to the physiological 7 to 8 as a maximum. So we have problems then in controlling our insulin with glucose. The areas of development that we're trying to approach that with are, of course, prevention of islet B cell decline so that there is physiological regulation, transplantation technologies which require immunosuppression, of course, islet regeneration technologies with islet B cells within the pancreas, and indeed using stem cell and islet B cell transplantation, and gene therapy, not beginning really in a clinical sense yet, but there are a few companies now looking at modification of tissues like muscle to produce insulin. Then we have insulin pumps, sensors, and closed loop systems I just mentioned, micro and nanotechnologies, and further developments of insulins and their regulations. I'm also going to address orally active, small molecule, modern insulin analogs into the future, and smart insulin systems. And there are a series of reviews of these areas in press largely in the last year or two. So very quickly, what about encapsulated microsystems for sustained subcutaneous insulin release? And the biggest problem here is that the words micro and nano don't apply to the kind of insulin load we're giving. We cannot get an insulin dose into a nano system, particularly when you try and couple it with other molecules which themselves require mass and space. So these things at the moment are still not really beginning, and as well as an insulin dose load problem, we have problems of burst release, we have problems in getting the right rate profiles for 24 hours and longer. So at the moment, a lot of work in these areas, but really it's not going any further. What about oral insulins? Well, these are superficially attractive, of course, because we want to get rid of injections. They're taken with food, and one idea is then that they match the food. The idea that you restore hepatic insulin secretion, first pass insulin secretion to the liver and make that physiological is also often touted as a reason for taking this forward. But this has problems. If we look at the Lispro studies with PEG-Lispro, which was a hepato-specific insulin, as I predicted, they got an increase in daytime hypoglycemia because of a failure to suppress the hypoglycemic rescue glucose secretion from the liver. And they got a rise in triglycerides and ALT. And these are markers of fatty liver, of course, and they would worsen the cardiovascular risk profile and mean these approaches would actually require cardiovascular outcome studies before licensing, which is why this insulin was abandoned. Further, there are profound technical problems, insulin digestion in the gut, insulin absorption across epithelia is very poor, and food, of course, interferes with the insulin profile. So far from matching to food, you actually get decreased insulin absorption with eating. If we look at what happens there then with oral semaglutide, the day-to-day variability is actually a huge increase by 140%. And that's why with oral semaglutide, you give it daily, whereas weekly, you can give it obviously every 7 days. By giving 7 doses over the week, you decrease the variability still to around 35%, which is okay for a GLP-1 RA. But would be really hopeless for insulin. So we have problems of poor bioavailability, erratic absorption, non-physiological absorption profiles, and hepatic insulinization. And there have been various attempts to overcome these, largely unsuccessfully. This is the long investigated now pegylated insulin from known as Tegrapel. There've been a series of studies here, but if you look at the profile of insulin that they're getting, then really we're getting a peak profile around 30 minutes, which might seem ideal as a mealtime insulin, but it doesn't last out to 4 hours. And the result of that you can see is the loss of glucose control that's occurring from around 60 minutes onwards. This, I think, isn't intestinal absorption at all. I think what's happening here is buccal absorption. And indeed, if you give this insulin with food, you very quickly abolish any insulin absorption at all. So this has been in development now for over 10 years and seems to be going nowhere. Then there was the Novo Nordisk insulin. It seems to have been abandoned. And I think it's been abandoned because with bioavailability of less than 2%, we got very high variability. fasting plasma glucose compared to our conventional insulin glargine was 90% higher in variability, and within patient variability was 52% higher compared to glargine. And these, of course, are not characteristics which are things that are happy to have with insulin because of the hypoglycemia problem, even if you do manage to get overall glucose control, which is similar. The Uramed insulin has gone further, but has huge problems. These are the phase 2 studies, phase 1, phase 2. You see with 8 milligrams, there was no increase in glucose lowering effect. With 16 milligrams, twice the dose of the 8 milligrams, they appeared to get no effect at all. And again, when looking at 32 milligrams in bigger and bigger doses, there was no increase in glucose lowering effect, suggesting, in fact, these aren't insulin at all. This is due to some kind of study effect. Indeed, baseline HbA1c was 8.9%. They got a reduction of about 0.5%, and that is the kind of reduction you see with studies anyway. And it's quite honestly a pathetic reduction compared to the hyperglycemia beforehand. They've gone forward into phase 3, and a stop press announcement this month was that phase 3 development in the type 2 diabetes study was completed, and we should see top line results early next year. But as I've suggested, I'm not very confident that we'll see a useful result here. What about faster acting analogs? Well, these have gone a little bit further in the last year. We, of course, already have faster aspart and Lispro licensed with some improvement in mealtime glucose excursions, but actually no clinical or useful improvements in glucose control or hypoglycemia overall. And furthermore, there have been some pump cannula infusion site problems. It's possible, in fact, that further developments in insulins will alleviate these problems. Within the past year, we've been told that the biochaperone Lispro from Adosia, together with the Chinese company, has started recruiting now into phase 2. And we've seen some new results with an insulin I hadn't heard about before, which I'll show shortly. The SurfBio ideas from Apple and colleagues continue to be better funded also over the last year. So this is the new AT278, and you notice that this is a high concentration insulin, which we'd expect to be much lower absorbed in fact. But compared to insulin aspart, the conventional one, we see this very fast rise to a peak indeed at 30 minutes and decreasing nicely out over 4 hours. So this is a very physiological peak. And it's getting the right pharmacodynamics, it seems, on the clamp studies. So this again looks very interesting. It'll need to go into phase 3 and be further tested to see whether we can get useful and better glucose lowering and improvement in mealtime profiles in phase 3. But this looks very encouraging. And of course, the U500 will be useful in type 2 diabetes. As far as weekly insulins go, as I commented last year, a lot of these seem abandoned, but the insulin icodec from Novo Nordisk continues to be developed in phase 3, and the Eli Lilly FC fragment coupled insulin similarly. If we look at these, the major problem with the weekly insulin is its peak-trough insulin. Once daily insulins have a significant peak-trough ratio, even the flat ones, but we can accommodate that by giving them at the best time of day. For one's weekly insulin, though, a profile with a peak and a trough is a potential disaster, because basically it means that on one day of the week, you'll be giving to your patient more insulin than you will at the end of the week. So a peak-trough ratio of 1.2 would, for example, mean a 20% higher dose, say, on a Tuesday than on a Sunday. And we'd expect as a result of that control problems and hypoglycemia problems. Thus, you need a very long half-life of the order of 3 weeks, but also after each injection, no kind of burst effect occurring at 1 to 2 days. This is the data from the Lilly insulin. There's little in the public domain at the moment, though they have submitted further material. You can see they're getting their peaks here around 3 days, possibly 4 days in human volunteers and type 2 diabetes similarly. But this actually is giving a half time of absorption, which is quite suitable at around 3 weeks. And the peak to trough ratio is about 1 to 1 or 1 to 1.5. So this probably is a tolerable peak to trough ratio for use in type 2 diabetes, though again, I would have my doubts for appropriate use in type 1 diabetes. This insulin is in phase 3, and perhaps we will see some results next year. This is the Novo Nordisk insulin. And this, I think, is a little more problematic, although, again, it is in phase 3 because the peak-trough ratios are somewhere above 1.34. So here on if we inject it on a Monday morning, on a Wednesday, you're giving 30 to 40% more insulin than you would by the Saturday. And this is likely to give problems over hypoglycemia during the week. Unfortunately, Novo Nordisk in their studies have not broken down weekly control as yet. There was one quality study from Rosenstock et al. Published in 2020 with some advantage over the conventional U100 insulin glargine, a small advantage perhaps, but certainly non-inferior to U100 glargine. But hypoglycemia underpowered in this study, so you can't really tell, but as a safety signal, a 70% increase in hypoglycemia, which, as I said, hasn't been broken down by time of week. But remember that figure, a 70% increase. Furthermore, insulin U100 wasn't optimal in that study as far as HbA1c was concerned. So this would be certainly a popular insulin. It would reduce the number of injections markedly, but it has its problems, I think. There was a press release on their Onwards 2 study, type 2 diabetes, at the end of last month. They did a 26-week study against Degludec. No difference against HbA1c demonstrated, but the headline effect for hypoglycemia was not happy. It wasn't statistically significant, but it was clearly underpowered because nominally 150% increase in hypoglycemia. So the problem that we saw in the Rosenstock study apparently being reproduced in the phase 3 study. We'll hear more about that, no doubt, later this year. Quickly, I'll move on to small insulin mimetics, non-peptides, if you like. difficult to engineer. Insulin's 3D structure is difficult to mimic. You notice perhaps on the artificial intelligence, we've now been able to mimic 30,000 different proteins for their 3D structure. And one of those is not insulin. It's not a stable structure, and it's difficult to imitate. Furthermore, we have troubles over the binding of insulin, which is complex with multiple sites of insulin interaction and conformational change on insulin. So these small molecule insulin mimetics, again, going nowhere at the time. So what about glucose sensitive smart insulins? We note that these are still largely to be given by subcutaneous delivery, and as such, they do not overcome the subcutaneous delivery problem with its half time of 45 minutes, as against the 5 minutes for intravenous insulin delivery. The idea, of course, is to modulate the activity of circulating insulin by plasma glucose, which again doesn't overcome the incretin problem, and it doesn't overcome the regulation on a 3 to 5 minute basis. So neither approach can emulate the reflex and incretin stimulated delivery of insulin. But it may be that these would give a very nice basal control if we could actually get an appropriate dose response curve between 10 and 5 millimoles per litre glucose. So how's this going? Well, of course, the lectin receptor competition for monosaccharide insulin with substitutions. Here's insulin, here's the saccharide substitution. And the idea is this would be removed by the lectin receptor when glucose concentrations are low. But if there was a lot of glucose around, these would actually block its removal, therefore increase the insulin concentrations, giving more insulin receptor mediated insulin effect. So it's a nice idea, but it didn't work out in practice. And this is the clear reason between normoglycemia and marked hyperglycemia. There was actually only a 25% increase with this Merck product in available insulin concentration. In practice, it looks as though you would require about a 10 times increase for normoglycemia and about perhaps a 5 times increase to get some useful insulin. They got a tiny increase. Clamp studies, no glucose dependent change was significant, and they returned the insulin to the developers and have abandoned it. The idea of a glucose-sensitive insulin, where insulin binds with high affinity to insulin and you lose the concentration to interfere with the shape of molecule, is quite interesting because maybe you'd get some intravenous and fast modulation. But there is actually no candidate and no insulin available at the moment. The way it works is simply, this is the insulin molecule that's active. You attach a side chain which interferes with the binding site so that the insulin becomes inactive. But when the side chain binds with glucose, it then moves out of the way and you have an active insulin again. So maybe this will be able to be taken forward if we can get a good enough dose response curve between glucose concentrations and insulin activity. We did hear that Novo Nordisk were going to promote one of those and tell us about the studies at the end of last year, but we've not had any further announcements even to the investment community. So my conclusions, last slide then, are that technical developments in insulin are making very mixed progress with ever faster acting insulins, which may be useful, but that's in particular, I think, within closed loop insulins. Weekly insulins may reduce the injection burden, but we have titration, we have weekly profile issue. Oral insulins seem unlikely at present to solve the problems of erratic absorption and low bioavailability, but I'd love to be proved wrong. Hepatospecific insulins are undesirable in the current obesogenic food environment. We'll hear a bit more about that from the next speaker. Small insulin molecules going nowhere because insulin is such a difficult molecule to imitate currently, and smart insulins still have to overcome the steep activity glucose response rate profile. I think regenerative medicine possibly can theoretically overcome some of these barriers because, after all, it moves towards IV sensing and IV delivery. But scientific progress is likely to be slow, and we will still have issues over physiological islets because they require very high oxygen tension to deliver all that insulin at mealtime, over control of cell proliferation. We don't want glucagon and insulin producing tumors, and over continued immunological issues. I thank you for your attention. Hope that was useful to you.
Thank you, Professor Phillips. It was a wonderful and elegant talk. Totally enlightened the whole history of insulin, and also given the nice information on the insulin history and the insulin biology, and given the insights on the abusive insulin therapy, the physiological need, and insulin profile in non-diabetic people, as we have given the beautiful insights, and increasing effects on insulin also given the good insights over that. And regarding the oral insulins also given a good information on the pros and cons. And you enlighten us on the upcoming latest mealtime analogs, so-called as U500 8248. And you emphasize more on the upcoming basal insulins, both with Lilly as well as the nowadays Pycoduct. And also we enlighten more on the glucose-sensitive smart insulins. Thank you very much for the wonderful talk, sir. Thank you very much. So without much delay, I go to the next sir. Yes, Manoj sir.
Can we ask a question? Is Dr. Home there?
Yes, Manoj sir.
Oh, Dr. Philip Home is there?
Yes,
I'm here still. I was not expecting questions, but if it's up to the chairman,
right. So
I'm happy to answer questions.
Yes, Dr. Home, as the chairman here and as the organizing secretary, let me thank you for that wonderful presentation, giving an overview of all the development of all the current insulins being developed. My question to you, sir, is amongst all these insulins that are currently in the development, which one are you most excited about?
You're cutting out a bit, so I missed exactly what your question. You said amongst all the insulins.
Manoj sir, your voice is breaking. Voice is breaking.
Okay, amongst all these new insulins, let me put my video off.
Yes, certainly.
Insulins, which one are you most excited about all from all these new ones?
Oh yeah, okay. I don't want to express preferences in the set for basal purposes in type 2 diabetes. The so-called basal insulin Lispro is looking good at the moment. It has the right profile. It has 3 weeks delivery. There will be titration problems getting there, but I think that is looking good. So in the shorter term, I think that's good. I like the Aracor fast-acting insulin. That seems to me to be getting towards a mealtime insulin profile, albeit unregulated, which is good, and that will be useful, I think, particularly if it's stable in closed loop and pump systems. So those two are the things I would be looking to. But, you know, I've been proved wrong happily before.
Absolutely. So we await those results. I think exciting times in the insulin development phase currently moving ahead, sir. Thank you so much.
It would be
Thank you.
it would be good to come to India and talk about these things in 2 or 3 years' time.
Absolutely. We would love to host you again, that time again in person.
Manoj, I request Jyoti Dev to take the next section. Dr. Jyoti Dev is online now. Dr. Jyoti Dev?
No, Karan, Dr. Jyoti may not have been able to join. So let me let me continue here and welcome Dr. Roy Taylor, who's the Medicine and Metabolism at Newcastle University and Newcastle Hospital NHS Trust, co-founder of the British Association of Retinal Screeners, qualified in medicine at the University of Edinburgh. I don't think Dr. Roy Taylor has been able to join us. We do have his recorded message and would request RX to start this.
Ladies and gentlemen, I'm delighted to join you here from Newcastle, UK. This first slide shows my research centre, the Magnetic Resonance Research Centre, because this is the technique we've used to look inside the body and unlock some of the secrets of physiology and type 2 diabetes. So let me move on without delay. None of my disclosures are relevant, and consider where this work started. It started back in 2006 when the idea occurred to me that type 2 diabetes had to be a simple condition. Our work to that point, and the work of others, had shown that insulin resistance in the liver was primary in causing the blood glucose to rise. But I was puzzled by these two defects. Why could such a simple common disease have two completely separate pathogeneses? In the textbooks, it was alleged that there were different causes for the different problems in the beta cell and in the liver and muscle, but that could not be. So I came up with the twin-cycle hypothesis that by eating just a little bit too much extra for a long period of time, excess liver fat would build up. We had shown that this would cause insulin resistance and plasma glucose to rise, but very clearly it was possible that excess fat in the liver would result in excess fat being exported to the rest of the body. Now, that should be stored safely in subcutaneous adipose tissue. But just what if the adipose tissue storage was relatively filled and it had to spill over into ectopic sites? Now, one of those ectopic sites is the pancreas itself. We'd known since the classical work of Roger Unger in the 1990s that chronic excess fat supply to the pancreas would cause a decrease in insulin-stimulated, glucose-stimulated insulin production. So beta cell dysfunction would result. That was the hypothesis. But of course, we could test it. And this is a matter of trying to destroy the hypothesis. We could instantly show it was wrong by taking people with type 2 diabetes, reducing their weight. The liver fat would surely go down. If their diabetes didn't go away, then the hypothesis would be wrong. Well, we did the counterpoint study, and this showed that in type 2 diabetes, there was indeed excess liver fat. There was indeed excess fat export from the liver. There was excess fat inside the pancreas, and we already knew that the beta cells did not work very well. But dramatically, with the weight loss in the counterpoint study, we were able to show that we changed this into normal levels of liver fat, normal fat export, normal pancreas fat, and restoring beta cell function. How do we do this? Merely by using a low-calorie diet. it had to be quite a strict diet, because for this study, we needed to observe the changes in a short period of time to be certain that we were really observing cause and effects. So the Counterpoint study confirmed that type 2 diabetes was a simple condition. We had to move on to find out more. And over the last 14 years, we've carried out 4 major studies, and the one that is just about to be reported, and I'll mention some of the data from Retune at the end. But the Counterpoint study, as I've just mentioned, showed that fasting blood glucose gets back to normal, absolutely normal, when we stop the oral hypoglycemic agents and start a low-calorie diet. Within 7 days, fasting glucose is normal. It showed the mechanisms, the 4 big mechanisms: the liver fat, the fat export, the pancreas fat, and of course, the insulin secretion. But it left open major questions. And so we carried out the Counterbalance study, which answered 2 major questions. Firstly, in Counterpoint, we'd studied people only of duration up to 4 years type 2 diabetes. What would happen with longer duration diabetes? Well, in Counterbalance, we studied people up to 23 years duration. And we showed very definitively that the shorter the duration, the more likely it was to get remission. And indeed, beyond 10 years, remission was not at all common. It also showed, this Counterbalance study, that remission was entirely durable. There is a myth circulating that beta cell function inevitably goes downhill in type 2 diabetes. But this has come about by studying groups of people who do not lose weight. They maintain the stress on the pancreas. The pancreas fat remains high, and surprise, surprise, beta cell function goes down. But specifically take away that metabolic stress, and the beta cell function returns to an adequate level and does not go downhill. That's sort of dramatic finding. We only observed it up to 6 months in Counterbalance, but in subsequent studies for much longer. But there were lots of people on the sidelines who said type 2 diabetes can't be that simple, and were very skeptical that the fat inside the pancreas had anything to do with it. Well, in the pancreas study, we achieved a demonstration that acute weight loss causes loss from the pancreas fat compartment only in people with diabetes. They start off high and they fall. I'll show some of those data. And then in the direct study, we showed that remission can be achieved in primary care. This is something simple that any doctor, indeed, as in the direct study, any nurse in primary care can achieve with sufficient information about how to support people lose 15 kilograms in weight. Now, this again is our MR Centre, and in the spring we have our lovely laburnum trees. But of course, looking at nature allows one to think. And if we just think about the points I've made, you'll see there might be a problem. Because some people with type 2 diabetes look normal weight. And indeed, in India, there are many people with a lowish BMI and type 2 diabetes. Could it be that there are the same processes operating then? Or is the diabetes really due to some mysterious other cause? Well, we can find out. And this whole thrust was powered by the personal fat threshold hypothesis, which I published together with Rory Holman in 2015. And the reason I published this was that I had had observed that people with unremarkable weights could get rid of their diabetes by losing weight. But of course, that was just clinical observation. If we consider 3 people, 3 men aged about 45, and if I was to ask you which one has diabetes, I think everyone would say, well, almost certainly this one, and possibly this one too. Not at all that one. But that's wrong. 10% of people with type 2 diabetes in the UK have a normal BMI. Now, adjusting that range for India, the same is almost certainly true. But let me make the point powerfully by showing you what each of these men looked like when they were not 45, but when they were 25. This man played chess and was a cross-country runner. This man played rugby and did weightlifting. This man did some of both. But you see, each of them have put on an equivalent amount of weight. Weight gain in adult life is almost 100% fat. We may like to delude ourselves, but if you weighed 70 kilograms at the age of 25 and you now weigh 80 kilograms, you have gained 10 kilograms of fat. So this weight gain will be fat, but what if the subcutaneous compartment was relatively small, the capacity was too small, and it spilt over at a lower threshold? Well, that person would then get the diabetes that we were observing. So individual thresholds for susceptibility to excess fat could determine the risk for type 2 diabetes. That was the personal fat threshold hypothesis. So let's test it. And we tested it in the Retune study. And the aim of the Retune study was to test this hypothesis. People who develop type 2 diabetes have stored more fat than their own body can manage. So a very specific personal message for the patient in front of you, nothing to do with epidemiology. Do remember that the larger a study is, the less relevant its results are likely to be for the person in front of you. What did we do in Retune? Well, we studied the mechanisms, of course, by looking at the big 4, the liver and pancreas fat, and the fat export, and the beta cell function. But we did this by achieving weight loss of first 5% and keeping it steady, then 10% and keeping it steady for a further 8 weeks, and then 15% and keeping it steady. And then we followed up people at 12 months. So this was trying to identify the threshold. How much weight did an individual need to lose to get rid of their diabetes? And anyway, in these people with a lower BMI, this is regarded as normal or very close to normal in the UK, would these people have excess fat causing their diabetes anyway? Well, this is a weight loss we achieved. Here we have the BMI. To start with, it was around 25, just under 25, and it went down exactly as we had planned. This group requiring 15% weight loss is relatively small and not representative because the protocol stated if people had already achieved remission by the second step, then they wouldn't proceed to the third step. But between the end of weight loss and 12 months, there was no weight regain. Here are the same data, just plotted as weight in kilograms. Down, down. So we could find out what would happen at each stage. But how about the headline figure? Well, in people who look slim but have type 2 diabetes, the total body fat content is grossly increased. In this group of people with a normal BMI, we found that they had a total body fat content of 32%. That's way above the normal range. The controls, matched for weight and everything else, had a fat content of 28%. So you see, there is excess fat. But is it there in the organs, and is it clogging up the processes in the same way that we now know for certain in ordinary overweight-associated type 2 diabetes? Well, the first point to make is that 70% of these slim people achieved remission of their diabetes. That's a dramatic figure. Taking people with a life-threatening condition, a high incidence of coronary heart disease, a high incidence of amputation, all the general ill health and premature death, and turning them back into normal people with a normal 10-year cardiovascular risk profile, that is quite remarkable. Now, what is remission? We say 70% achieved remission. Well, just last year, an international consensus panel to which I contributed defined HbA1c of 6.5% and less as being remission off all hypoglycemic drugs, and provided there are 2 tests of HbA1c, a repeat at 3 months to demonstrate that the remission is still solid. So we could take people out of this range of diabetes, but what was really happening inside the body? Well, here I show you the data from our direct study, which had overweight and obese people, and you'll see that in type 2 diabetes, liver fat was really very high compared with the controls. But there was a surprise with the retune data set because liver fat seemed to be in the normal range. How could this be? Well, of course, this is a matter of calling into question what we assume is normal. You'll remember that this figure of 5.5% liver fat as being defined as the border of normality was derived in the San Antonio Heart Study. And this was conducted, of course, in America. And in America, the population is not notably thin. This normal range has been devised on an overweight population. If we look at people who are matched for BMI, you'll see that there is over a 2.5-fold difference here between people with diabetes and those without, and over 2.5-fold difference here. There is excess liver fat. And indeed, the threshold we identified in retune was that weight loss of approximately 6.6% of starting weight would achieve remission of type 2 diabetes. That clearly related to this fall in liver fat from a level that is grossly abnormal for a person of this body mass index. Similarly, with the pancreas fat, we showed the small difference we've already described as being present between non-diabetic and diabetic, and indirect. This fell during the weight loss. Also in retune, there was a highly significant difference between diabetes and non-diabetes. So we can be confident that this is a condition of excess fat in the organs, whatever the BMI. Well, let's go out into Newcastle City itself. This is our new castle. It gave rise to the name Newcastle, but in fact it was built in the year 1186. And only 300 years later, our cathedral was built, and it's still standing from 1486 to the present day. But in Newcastle are all the people. How do we take this science out to the people? Well, we have to define exactly what it is we need to do. A diet for weight loss. What are the characteristics of this? And in producing this slide, I'm bearing in mind the natural cultural differences, say, between India and Newcastle. Of course, people need to eat differently in these places, but the diet we need for weight loss really transcends that. The first point about it is that it has to be simple and practical for people to be able to follow in their everyday life. We need to recognize that individuals find it very difficult to diet because humans are social eaters. We eat in family groups. We eat with friends. And for that reason, it's absolutely vital that the spouse or partner is on board right from the start. Please don't send an individual to see a dietitian. In fact, unless the dietitian is tuned into this matter of weight loss, don't send them to a dietitian at all. Because we need a very specific approach to losing 15 kilograms in a short period of time. And this short period is important. Not because we wouldn't get the same effect if we lost this weight over a much longer period. Of course we would. It's just shifting the fat out of the pancreas just the same. It's the human factor. It is more difficult to lose weight slowly. On the low-calorie diet, hunger, remarkably, is not a problem. People are quite happy on this. Indeed, one of the main problems is persuading them to come off it at the end and get back into normal eating. So duration limited is important because this is goal-directed behavior. You want successful treatment. Your patient wants a successful outcome. We need to achieve this in a humanly defined period of time. 8 weeks in the Counterpoint study. So, what else can we say about this matter? There's one really important point. The textbooks and the magazines are full of exercise for weight loss. And in respect of the weight loss itself, I have one message for you. Don't do it. When people with type 2 diabetes embark upon a diet, embark upon exercise, they will indulge in compensatory eating. That's why, as many people in this audience will have found out for themselves, starting an exercise program is usually followed by no change in weight. If an exercise program is started at the same time, it's more difficult to lose weight. So focus upon what's important, weight loss. Once the weight loss is completed, physical exercise is really very important to encourage to help prevent or slow weight regain. But we need to be quite clear that we need both, but frame shifted in time. Lose weight first. Do not exercise during this time. Then increase the amount of exercise. Your patients will come back and say, I feel 10 years younger. I can play with the grandchildren again. I can run up the stairs. Exercise becomes feasible when it has been very difficult before. So what is the wider program? Well, the wider program is to achieve weight loss rapidly. And we used a 600-calorie liquid formula diet and non-starchy vegetables, such as salad stuffs and any leafy vegetable. But the nature of the diet is much less important than the amount. Secondly, to move from this back towards normal eating, we stop one of these meals and introduce just a normal meal, but a small meal. And this defined amount of food to eat is quite important to mention. Here we see the entire day's allowance of non-starchy vegetables piled on the plate. And these are our diet replacement products made up in a pint of water. There is your breakfast. There's your lunch. There's your dinner. This achieves one of the important things about a diet. Usually, one of the big problems of losing weight is the day-to-day burden of decisions. Can I eat this? Can I eat that? This burden is cumulative. But by simplifying this to very clear instructions, we avoid this problem. Now, this diet is something that doesn't have to be used, but in one particular study in India, it was indeed used, or a similar diet was used. Now, it was felt that 1,000 calories a day would be more acceptable, and indeed, this demonstrated that 50% of people had no diabetes at 12 weeks. They had only lost 6.5 kilograms in weight, but just look at their HbA1c drop, and oral agents were stopped at this point. You can see this is real, this is practical and doable. Long-term avoidance of weight regain remains the big challenge. But let me put over to you some really important points. Diabetes does not recur if the weight loss is maintained. So if people avoid regaining weight, they will stay free of diabetes. That is, until very late on in life, when mobility is severely impaired. Very quaintly, they will get maturity onset diabetes, and it doesn't matter beyond the age of 80. It is not a serious condition. It's people getting type 2 diabetes in early life who have the most problems. Now, this is a challenge to avoid the weight regain. A few people can indeed manage it by themselves. They are self-motivated, but most people need ongoing support, and this is absolutely critical. So you may well achieve freedom from diabetes for your patient, but your patient still needs to come and see you for the ongoing support, because there is 100% certainty. Few things in diabetes can be said to be 100% certain, but this is one. There's 100% certainty that diabetes will recur if weight returns to its previous level. You can promise your patients that, and you can promise them that things are likely to be better if they continue to come and see you on a regular basis for the weight to be measured, for a discussion about their physical state and also their physical activity. So, if I was to pose the question, what is type 2 diabetes? I hope you'll now agree with me that type 2 diabetes is a state of excess fat inside liver and pancreas. And more than that, if we remove that fat, the diabetes can go away, provided the beta cell damage has not become too established, with duration of diabetes being too long. But importantly for India, with low BMI type 2 diabetes, Retune confirms the same pathophysiology as in heavier people, and the same remission with weight loss. So, major implications for clinical care. That takes us back to the magnetic resonance center. And in the early spring, we have this beautiful cherry blossom, a nice place for people to sit and think. But I hope you now think what I think about type 2 diabetes. It is a simple condition of excess fat inside liver and pancreas. And recognition of the personal fat threshold is important. It's the most understandable concept for patients. When I explain this to them, they seize it much more rapidly than any other concept. And type 2 diabetes can be reversed by simple means. Now, simple shouldn't be confused with easy. is a challenge for anyone, but with support and with focus upon what's important, this is something you can achieve for your patients. Thank you.
Oh, thank you very much, Professor Robert. It's a wonderful session and very excitable also, because already we're one of the directors for the direct trial, and we have enlightened more on the good insights on the twin cycle hypothesis, the importance of the liver fat and pancreatic fat, and paving the way for the diabetes. We're given the interlink between the pancreatic fat and this one liver fat, and also type 2 diabetes, and even the importance of both the calorie restriction and the weight loss. And more than that, even the real hypothesis on both the direct trial as well as the Newton study and hypothesis. Thank you very much for the great enlightening talk, sir. Thank you very much. Over to Professor Manoj Chawla.
No, I think we had a great session, and would like to thank all the speakers who've taken time out and joined us from different parts of the world for this wonderful session. And of course, thank the chairpersons and doctors helping us with the hall, Dr. Snelata Verma, Dr. Karan Natarajan. Truly appreciate your efforts for Diabetes India and that Congress. Would like to thank again Dr. Philip Holm for joining in and staying back, and RX Events for helping us with this entire aspect. So, Dr. Holm, many regards, and thank you again for the teaching. We surely would love to have you here in person again in India in the near future. We look forward to that. With that, we end the session, and have a wonderful Sunday, everyone.
Thank you, Manoj. Thanks.
Thank you, sir. Thank you, everyone.